Welcome everyone. Today we will have a couple of topics. Dr. Malaz and her team will be discussing visual loss and disorder, Rayyan, public speaking skills, and project management. And we will have some updates at the end. So please, Dr. Malaz, when you're ready and your team, go ahead. Thank you.
Hello, everyone. Thank you so much, Dr. Nader. I'm Dr. Malaz Salah, and I'm really delighted to be moderator for today's meeting. Before begin, I would like to thank Dr. Nader for your continuous mentorship, encouragement, and support, and your guidance continues to inspire us and strengthen our research journey. And I would like to give a special welcome to all our new fellows. We are excited to have you join the TGRF team. You are now part of a diverse and supportive research community. We are learn together, exchange ideas, collaborate, and turn those ideas into meaningful research. We hope this fellowship will be an inspiring and rewarding experience for every one of you. And a very warm welcome also goes to all our presenters and fellows joining us today. Thank you for making the time to attend and contribute. And of course, a special thank to today's presenter for the effort, preparation, and they have brought to this session. We are very excited to hear from each of you. So regarding our agendas today, we have reached a diverse and exciting program, as mentioned Dr. Nader. So our first presentation will going to be about the visual loss and disorders presented by Dr. Nahid. And our second presentation will going to be about the public speaking skills and going to be presented by Dr. Raghad. And our third presentation is project management principles, will going to be presented by Dr. Nabiha. Our fourth presentation and final will going to be about Rayyan, a screening tool for systematic review, which I will have the pleasure of presenting. Following the presentation, we will move to our project updates, opening discussions, and final comments and recommendations from Dr. Nadir. So let's must begin with our first presenter, Dr. Nahid. We are starting today's meeting with an important clinical topic, visual loss and disorders. So, Dr. Nahid, if you are ready, the floor is yours. I'm gonna share your screen.
Yes, I'm ready. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to our presentation today. My name is Nahed Abdelhadi. I will be presenting for the first topic, visual loss and other eye condition. So today our objectives will be the leading causes and pathophysiology of visual loss, techniques for preventing and treating visual loss, the science and treatments for common eye disorders in older people, and techniques for low vision rehabilitation. So we will cover common eye conditions, causes of visual loss, especially refractory errors, cataract, age-related macular degeneration, diabetic retinopathy, glaucoma, ischemic optic neuropathy, and at the end we go to low vision rehabilitation strategies. Next, please. Impact of visual loss, either visual impairment or blindness. In visual impairment, the acuity will be less than 20/40, and the prevalence increase with age. Affect 20% to 30% of those age 75 years and older. Blindness, we'll see the acuity will be less than 20/200, and the prevalence is 2% of those age 75 plus, and 50% of blind population is age 65 and older. Next, please. So the screening to prevent visual loss, the American Academy of Ophthalmology recommends comprehensive eye conditions every 1 to 2 years for people aged 65 years and older. Common eye conditions in older adults, usually elderly will see red eye, ocular swelling or discomfort, diplopia, sudden loss of vision, and floaters are common eye complaints. We need to ask, has your vision changed? And then decreased vision can be indicate a serious condition. So we have to check a visual acuity and check for afferent papillary defect. Next slide, please. Here, there is signs and symptoms of eye conditions required immediate referral to ophthalmologist. In retinal detachment, we will see flashes, floaters, decreased vision, keratitis over vision, and in acute angle glaucoma, usually patient present with eye pain or headache, ocular hyperemia, hazy cornea, fixed dilated pupil, decreased vision, nausea, and vomiting. Ischemic optic neuropathy, the presentation will be sudden loss of vision, either complete or partial in one eye. Swollen optic nerve will be finding on examination. In central or branch retinal artery occlusion and ginsel arteritis will usually patient experience sudden painless loss of vision in one eye or in superior or inferior hemifield in case of branch occlusion. And if from ginsel arteritis, then review of systems may reveal local education, headaches, transient diplopia, and other symptoms related to ginsel arteritis. Artery occlusion requires stroke protocol within 2 weeks of event. Next slide, please. In retinal vein occlusion, the symptoms and signs, it could be sudden painless, vision loss diffusely if central, or in one hemifield if only one branch vein involved. Prominent retinal hemorrhages and cotton wool patches on fundoscopy. In scleritis, there is eye redness, severe pain, and or tenderness, decreased vision, and usually associated with autoimmune disease. In anterior uveitis, we'll see photophobia, eye redness, and decreased vision. Posterior uveitis, floaters, and decreased vision. And in corneal ulcers, we'll see eye redness, pain, decreased vision, and corneal infiltrate. In uveitis, patient present with photophobia, eye redness, and decreased vision. Herpes zoster ophthalmicus, there is eye redness, pain, burning, rash, decreased vision, light sensitivity, and there is characteristic skin lesion, which is called Hutchinson sign. Next, please. Here, the treatment of eye condition commonly seen by primary care provider. In subconjunctival hemorrhage, usually we treat it supportively with artificial tears and supportive management. And dry eye, artificial tears, cyclosporine 0.2% eye drops. Blepharitis, we do late scrubs, ophthalmic antibiotic ointment, usually given once a day at night, and then oral doxycycline. Lid malposition or lid exposure, there is some ocular lubricant, refer for surgical repair. Allergic conjunctivitis, we do cold compression, allergen avoidance, topical and systemic antihistamines. Next, please. In viral conjunctivitis, the management usually supportive with artificial tears and refer to ophthalmologist if vision significantly affected. Ankylosing warm compression may refer for excision. Herpes simplex keratitis, trifluridine eye drops are refer for ophthalmologist. Herpes zoster ophthalmicus, tear drops are refer to ophthalmologist. Angle close glaucoma, acetazolamide, oral or IV, and then refer urgently to ophthalmology. Next, please. In Case of flashes and flutters, refer to ophthalmologist immediately because it may be due to retinal detachment or vitreous hemorrhage. In sudden decrease in loss of vision or decrease in vision, we need to refer also the patient immediately to ophthalmologist because it could be secondary to a number of vision-threatening problems. In diplopia, it could be like monoocular or binocular. In the monocular, the cause usually refractive errors or cataracts, and binocular is microvascular infarct to cranial nerve and ginsal arteritis and compressive tremor. This is a tumor. Sorry, this is the common cause of binocular diplopia. Next, please. I will cover selected topics briefly, which is commonly seen in elderly population. So we start with keratitis sega, dry eyes. There is problem in tear production, decrease with age, and characteristic patient become present with redness, foreign body sensation, and reflex tearing. Management usually artificial tears during daytime and ointment at bedtime. Sometimes we use topical cyclosporine or a 0.2% eye drops in severe cases to treat underlying inflammatory causes. Treat accompany blepharitis as well. Next, please. In lid abnormalities, common among older adults, elasticity and tensile strength are gradually lost with age. Blepharocholiasis, اللي هي dropping of the eyebrow, blepharoptosis, dropping of the eyelid may cause cosmetic deformity. And if severe, can affect the vision and make impaired vision. Lid ectropion eversion or entropion inversion may cause discomfort. Treatment, various surgical procedures can help. Next slide, please. Herpes zoster ophthalmicus. There is painful reactivation of varicella zoster virus, dermatomal distribution of weeping vesicles affecting the ophthalmic branch of the trigeminal nerve. Hutchinson signs, which is lesion found in the tip of the nose. We use for management of herpes zoster ophthalmicus oral cyclovir or famciclovir. It may help to shorten the course of the disease, and in post-herpetic neuralgia, because it's debilitating condition, so we treat it by local ointment to the skin, capsaicin and lidocaine, or treat with systemic medication like painkillers, usually narcotic, tricyclic antidepressant, gabapentin, and pregabalin. Next, please. Refractory errors leading cause of visual impairment worldwide, along with cataracts. Treatment with eyeglasses, contact lenses, laser refractive surgery. Ametropia, which is spectrum of myopia, hyperopia, and astigmatism. In myopia, there is nearsightedness problem, hyperopia, farsightedness, and astigmatism, there is visual distortion. Presbyopia, which is decreased ability to focus on a near objects, begin after the age of 40, and usually caused by gradual hardening of the lens and decreased muscular effectiveness of ciliary body. Next, please. Cataract, the symptoms include increased glare, decreased contrast sensitivity, decreased visual acuity, change in color perception. And the risk factor usually increased age, decreased vitamin intake, light exposure, ultraviolet, especially ultraviolet B light exposure, smoking, alcohol use, and long-term corticosteroid, and finally diabetes mellitus. The percentage of population with cataract over 65 years, 20%, and over 75 years of old, it reach up to 50%. Next slide, please. Management of cataract includes surgical extraction. 90% of patients achieve vision equal or more than 20/40. 3 million surgeries are performed annual in US. local or topical anesthesia, a small incision, sonographic breakdown, and then aspiration of the lenses, and at the end, placement of an artificial lens. Next, please. Age-related macular degeneration, which is most common causes of irreversible blindness among older adults in developed country. Risk factors include increased age, genetics, smoking, and hypertension. Diagnosis, presence of drusen, which is non-oxidative form, or choroidal neovascularization. We see it in oxidative form of age-related macular degeneration. We treat it with vitamin C, vitamin E, zinc, lutein, and zeaxanthin. Zeaxanthin to decrease risk of choroidal neovascularization in non-oxidative forms. Also, intravitreal injection of vascular endothelial growth factor inhibitors to treat the choroidal, also neovascularization in oxidative form. Next slide, please. Here, the age-related macular degeneration treatment. We see the resolution of hemorrhage after the intravitreal injection of vascular endothelial growth factor inhibitor. So in picture A, the brief fundus with age-related macular degeneration, and then there is the resolution and improvement here in the fundus in picture B post-treatment. Diabetic retinopathy, the epidemiology among people who have had type 2 diabetes at least 10 years, 70% show retinopathy, and nearly 10% show proliferative disease. Most important risk factors include duration of the disease, control of blood sugar, and blood pressure. Prevention, like start with diet glycemic control, which is contrapulsar point, and blood pressure control. However, target should be individualized, especially in pediatric patients. There is no cut limit, just individualized. And also should optimize kidney function and cholesterol. Treatment, laser treatment, and intravitreal injection of anti-vascular endothelial growth factor also, and control of blood glucose and blood pressure. In diabetic retinopathy stages, we see 3 stages: non-proliferative, pre-proliferative, and proliferative. Next. So in non-proliferative, usually we see microaneurysms, intraretinal hemorrhages, exudates, and macular edema. Next. In pre-proliferative, we'll see multiple intraretinal hemorrhages, venous caliber changes, intraretinal microvascular abnormalities, include capillary shunting, and capillary non-perfusion or ischemia. Next slide. Here, the proliferative stage of diabetic retinopathy, we see the fundus before management, before is there is severe non-proliferative diabetic retinopathy, there is macular edema, and then after inject an anti-VEGF therapy, the fundus improve, the ischemia is less prominent, and neovascularization decrease. So the last stage is proliferative retinopathy, in which you will see neovascularization of the retina, neovascularization of the disc, and visual loss due to vitreous hemorrhage or traction retinal detachment. Here, there is resolution of severe neovascularization of the disc after use of anti-VEGF therapy in proliferative stage. So picture A before the management and picture B after medication, we see the fundus is bit clear and the disc is now, the vascularization decrease. Okay. Yes, you can go to the next slide. Thank you. So we go next to glaucoma, defined as a characteristic optic nerve head damage and visual field loss affect more than 2.25 millions of Americans at 40 plus years old, and the second most common cause of irreversible blindness worldwide. Most common causes among Black Americans. More than 3 million office visits each year. It's very common. And then elevated intraocular pressure is a major risk factor, but many patients with glaucoma have normal pressures. Next slide. So, will primary open angle glaucoma, most common form of glaucoma. There is slow aqueous draining, lead to chronically elevated intraocular pressure. Patients are asymptomatic and may suffer substantial visual loss before consulting an ophthalmologist. Causes are multifactorial and polygenic. Next slide. In acute angle glaucoma, precipitous increase in intraocular pressure, redness and pain with acute visual loss, and often headache, nausea, and vomiting. This emergency condition, so emergent ophthalmologic referral is required. Next slide. In the management of glaucoma, we use intraocular pressure lowering medication, either local or systemic, and the idea is that to suppress the aqueous production or to facilitate outflow facilitator for the aqueous. And also we can go to laser trabeculoplasty and filtering surgery plus minus anti-metabolite medication, and draining devices, and finally cellular body destructive procedures. Next, please. Next slide, please. Anterior ischemic optic neuropathy. There is microvascular occlusion of the blood supply to the optic nerve due to atherosclerotic vascular disease or inflammation. Example, temporal arteritis. Result in acute vision or field loss. Next slide. Here, the anterior ischemic optic neuropathy, there is palate swelling of the optic nerve head in an older adult patient with anterior ischemic optic neuropathy. Charlie-Brand syndrome is visual hallucinations experienced by patients with significant visual impairment, may be elementary shapes or complex, such as children or animals. And patients have a clear sensorium, are aware that vision are not real. So low vision rehabilitation techniques available in patients with acuity usually less than 20/60, improve lighting and provide reading material with bold, enlarged fonts and accentuated black on white contrast can help. And magnification, example, high plus spectacles, magnifiers, closed circuit TV and telescopic devices. And patients with macular degeneration, there is eccentric viewing for those patients, especially if they have central macular pathology. So we train them to use off-center fixation. There is some talking devices or braille for those who have lost vision altogether. And finally, there is smartphone apps can provide magnification, monitor recognition, and dictation functions. Next, please. So choose wisely. Do not perform preoperative medical tests for eye surgery without specific indications. Most cases of acute conjunctivitis have a viral etiology. Do not treat viral infection with antibiotic. If diagnosis is uncertain, patients may be followed closely for resolution. Do not place temporary or permanent plugs for mild dry eye syndrome before trying other medication treatment. Next slide. So in summary, visual loss occurs commonly among older adults and may lead to reduced quality of life, high medical care costs, and loss of independence. Primary care providers should routinely screen older adults for visual loss, and treatment options are available for many types of visual loss. Next. We go through some cases just for consolidate the understanding of the topic. First case is an 84-year-old man is brought to the office because his right eye is red. He seemed to have cold and sneezing. There is a moderate water discharge. He says that the eye feels gritty, but do not itch. He has no eye pain or sensitivity to light. There is no baseline information on visual acuity, but he thinks his vision is unchanged. Nursing home staff confirms that there is no evidence of a change in visions. History of Alzheimer's disease examination showed eye movement are intact. There is moderate bulbar conjunctival injection of the right eye. Conjunctival hemorrhage extend from 6 o'clock to 9 o'clock positions. Right periocular lymph node is slightly tender. Next slide, please. Which one of the following is the most appropriate management of red eyes? Antibiotic eye drops, referral to ophthalmologist if artificial tear as needed, antihistamine eye drops. If there is any idea or okay, so we can go from next slide, please. Malaz. So this patient case of viral conjunctivitis, management usually supportive. So we will go to artificial tear as needed. Next slide. A 90-year-old woman is considering whether to have cataract surgery. She's able to read large print books on her e-book reader and solve crossword puzzles, two of her favorite activities. She's able to do that. She had bilateral wet age-related macular degeneration and received anti-VEGF therapy. The left nuclear sclerotic cataract has worsening, and her vision in her left eye has decreased from 20/40 to 20/80. Vision remains in 20/60 in her left eye. She's a frail. She moved to a nursing home from assisting living 1 year ago when she's began to need assistance with bathing, dressing, and toileting. History of AMD, aortic stenosis, percutaneous aortic valve replacement 2 years ago, asthma and osteoarthritis. Next slide. Which one of the following is the most likely outcome from cataract surgery? Like a more rapid progression of AMD in left eye, correction of vision, loss in left eye, improved ability to read and solve cross puzzle, and better monitoring of AMD. Any idea? Okay, for this patient, I think, next slide, Malaz. For this patient, we need to monitor her AMD. So better monitoring AMD. Finally, we have the last cases. Next slide, please. Last case. He's a 75-year-old man. Is seen for routine follow-up related to diabetes mellitus, which is not under optimal control. He's apparently that his right eyelid is drooping. He said that he has been aware of the drooping for the past few months, but is not bothering by it. He has no double vision or blurring vision. He has not noticed any difference related to sweating on the right side of his face. There is no new muscle weakness or pain. Examination, the right upper eyelid cover the cornea almost to the pupil. The pupils are equally rounded and reactive to light and accommodation. Extraocular movement are intact. The eyes are aligned and his face is symmetric, except for the lid creases. Next slide. Which one of the following is the most likely cause of this of his blepharoptosis? Prolapse of the orbital fat bag, Horner syndrome, Turner palsy, or levator dehiscence.
Turner palsy.
Any other idea? Thank you. Okay, so next slide. This patient case of levator dehiscence being long-standing diabetes, and in Turner palsy there is no other manifestation. The pupil is equally reactive, so we go with levator dehiscence. Thank you so much for listening. Thank you, Dr. Nadir. If you have any question, please go ahead and ask.
Thank you so much,
Dr.
Dr.
Nahid.
Nahid. Go ahead, Dr. Malaz, go ahead.
Thank you so much, Dr. Nahid, for your informative presentation. Anyone have any question or want any experts you can say or to share any information?
Okay, thank you so much.
Okay, if no one have any question, let's move to the next presentation. We have presentation about the public speaking skills. We're going to be presented by Dr. Raghad. Dr. Raghad, if you are ready, or Raghad, I'm sorry. If you are ready, the floor is yours. You can start.
Yes, I'm ready. Just a second, let me share my screen.
Yeah, it's okay.
Okay. So can you hear me?
Yes, your voice is clear and the screen is clear too. You can start.
Okay, thank you very much, Dr. Malaz. Thank you very much, Dr. Nahid. Good evening, everyone. My name is Raghad. I'm very excited to be here with you guys today. I'll be presenting a few words on the importance of public speaking and how to step up your public speaking skills. So what is public speaking? Public speaking is a process, an act, and an art of making a speech before the audience. Public speaking is a foundational communicative competence essential in both educational and professional settings. So within educational contexts, public speaking serves as a primary method for assessing one's knowledge and comprehension and is acknowledged as a critical component for fostering graduates' employability. So just to talk a little few words about evolution and history of public speaking. It dates back to the development of democracy in Athens, which gave birth to sophism. Sophism is emphasized as logical reasoning and the use of arguments to persuade people. So this is what led to the development of the art of rhetoric, which is a skill of speaking effectively and persuasively in public. And the Greek philosopher and polymath Aristotle set a few rules called Aristotle's first set of rules for public speaking, which dates back to 384 BC. There are three important factors, ethos, logos, and pathos. So ethos is the credibility and character of the speaker. The audience is more likely to trust the speaker who is knowledgeable and ethical. Logos refers to the arrangement of ideas, words, and arguments. So this appeals to the audience's reasons and evidence. Pathos is the ability to create an emotional connection with your audience. So it appeals to the audience's feelings and emotions. So ethos, which refers to the credibility, your trust. Logos, to the logic or the reason behind it. and pathos as the emotional connection with your audience. The speech structure today, however, is divided into 3 simple parts: the beginning, the middle, and the end. Think of it like making a sandwich. So the beginning is what grabs your attention, the middle is the filling where you share your ideas, and the ending is what brings everything together and leaves the audience with something to remember. So the opening is the first impression of your speech. Its purpose is to grab the audience's attention and make them interested in what you're about to say. You can usually start with a question, a surprising fact, or a short story. After that, you can briefly introduce yourself and tell the audience what you'll be talking about. The next is the theme or the body of the message. It's the main part of the speech. It's where you explain your key ideas and you support them with examples, facts, or stories. It's important to keep your points organized so the audience can actually easily follow your message. Each point should connect back to the main topic, and you should know your audience inside and out. Try to use personalized experiences if you have any, anything that happened to you in particular, so you can just take them on this journey with you, and the audience can really follow what you're trying to say. The closing or the conclusion is your final chance to leave an impression. So it should summarize your main points and it should remind the audience of your key message, or should end with something memorable, such as a call to action, a powerful quote, or a thought-provoking statement. Think of it as this way. A good speech is like a journey. The opening is what invites the audience, the body is what takes them through your ideas, and the closing is what leaves them with something they'll remember. Okay, so research has shown that public speaking is consistently ranked as one of the top 10 fears worldwide. People are genuinely terrified of standing in front of an audience. Despite its recognized importance, public speaking naturally evokes anxiety, worry, apprehension, and in some severe cases can cause panic and avoidance behaviors. I think we've all been there, whether we've experienced it ourselves back in the day, early on in our careers, or witnessed someone else going through it. Standing in front of an audience with your heart racing, hand shaking, genuinely forgetting what you want to say. This reaction is quite common, very common actually, and it shows how strongly our bodies respond to the pressure of public speaking. Why it actually matters? So a recent review in Frontiers in Human Neuroscience analyzed nearly 1,000 studies conducted over the past 30 years and found that public speaking is no longer just viewed as an academic skill. It's now essentially what influences academic success, leadership, career advancement, patient communication, teaching and research presentations, and communications in increasingly digital and virtual environments. So another study conducted in 2022, cited below, measured self-reported anxiety, speech performance, speech duration, and physiological responses, taking into account heart rate, blood pressures, breathing rate, sweating, shaking, and dry mouth. Concluded that people with higher self-reported anxiety gave shorter speeches, rated themselves as poorer speakers, but were also judged by observers as having somewhat a lower speech quality, which is expected. However, physiological measures such as bodily reactions did not reliably correlate with how anxiety reported feeling. So our takeaway is feeling nervous does not necessarily mean your body is reacting more dramatically or that your audience is noticing as much as you think. So next up is retention and key audience drivers. This one will surprise you a little bit. So what actually keeps an audience engaged? Research consistently shows that it's not just what you say, it's how you deliver it. So the biggest driver of audience retention is storytelling and personal anecdotes, with about 90% impact. People may forget facts, but they will remember stories because they're relatable and it's what creates an emotional connection with the audience. The second most important factor is international pacing and pauses. So speaking a little slower and using your pauses gives the audience time to absorb your message, and it's what keeps them engaged. Next is your vocal modulation and tone. Changing your pitch, volume, emphasis, small changes like that prevents your presentation from sounding monotonous, and it's what helps highlight your key points. Interestingly, visual aids and slide texts and slide designs are ranked a little lower. So good slides are helpful, but they're not what fully grabs the attention of your audience. It doesn't compensate for your poor delivery. So your audience is listening to you and not really reading your slides. So the key message, the key takeaway is that people connect with speakers and not slides. If you can tell your story using your voice effectively and pace yourself well, you'll keep your audience attention far better than by adding more text to your presentation. Okay, so public speaking is more than just standing in front of your audience. It's a career skill, and it's what helps get your ideas across. It's what influences others and helps grow professionally. So let's start with 3 reasons why public speaking matters in our careers. Number 1, it's what creates opportunities. So public speaking creates opportunities by making your knowledge more visible. So a person may have strong ideas, but if they can't communicate them effectively, those ideas might go unnoticed. And strong speakers are able to influence stakeholders, gain credibility, and open doors to new projects, promotions, and professional relationships because of their effective public speaking. In consulting, communication is not just a soft skill. It's a part of your delivering value. So as doctors, we're not only hired to analyze problems, but to convince clients and to present recommendations, and it's what drives actions. So your ability to speak with clarity and confidence can directly affect client trust, project success, and future opportunities. Public speaking skills is what gives you your influential power. So your ability to speak well can enhance how you share your message. Your ideas can guide and empower others. Your storytelling and presentation skills can make an emotional connection with your colleagues, your teammates, your managers at work, which can then open them up to your ideas and eventually to their ideas as well. So effective verbal communication can help others consider a completely new topic or one from a completely different point of view. And it's what gets facts across, opinions, and even anecdotes to ponder and act on. It has the power to change lives, and it can lead to career growth, and it's what helps careers move forward. Number 3, public speaking can greatly improve your self-confidence. The fear of public speaking or speaking in front of any small or large group of people is a common phobia that causes anxiety and stress, thereby diminishing self-confidence. However, if you conquer the fear and master your public speaking skills, it will have quite the opposite effect. So public speaking is a very essential component that can help you advance, create collaborations, build networking opportunities, and enhance your leadership skills. By practicing and continuing to improve your skills, your comfort level will increase, and you'll then be able to feel the difference in your own self-confidence. Now that we know why public speaking is important for career success, the next question is, how do we get there? How do we improve the skill? So here are 5 tips that we can all use for our next presentation. Number 1, practice and revise. So it should go without saying that you need to know your material and not just memorize the key points and facts that you have, but knowing how you'll get your audience engaged and keeping them interested from start to finish. So when you have a short or a very long presentation to memorize, breaking each component down into smaller pieces is what helps organize your speech. So for example, in short presentations, you can divide into simpler pieces such as introduction. As I already mentioned, you start off with a short quote or a personalized story. Then you move on to your main content, which is your facts and your key points that you get across. And you finally end with your conclusion that wraps up your presentation, or it's what ties it into the original story. This is extremely helpful if you get distracted or interrupted, because you'll be in an environment where you'll have people will have the space to freely ask questions. So it opens doors for interruptions, and you'll need to quickly get back on track. So break down your presentation into pieces. Practice each piece in order and out of order, so that when you do get lost or distracted, you'll know how to get your way back. Number 2, slow down. So according to the very famous American writer and humorist, Mark Twain, there are only 2 types of speakers in the world, the nervous and the liars. So nervousness is inevitable, even for experienced speakers, and it affects how you speak in front of people. It often contributes to much more than just rapid speech. And when you speak fast, your audience will pick up on your nervousness. They will get distracted and they will not understand what you're trying to say, and you thereby lose their confidence in your expertise. And a simple remedy is to just slow down and speak very slowly. Speak your words, enunciate each syllable as you practice. Don't be afraid of the pauses while speaking. Let the audience digest what you're trying to say. This is called the pacing rule that I've mentioned below. So number 3 is remove any stumbling blocks or remove the obstacles. While speaking, speak slowly. Enunciation is a great way to keep you from stumbling your words and phrases. So sometimes the words you choose may hinder your flow, causing you to trip up, get lost, or fumble a little. So if you're struggling with a line or phrase while trying to practice it, consider changing it. If it's a hard one for you, consider changing it to a simpler one. For example, if you stumble over the word utilize, for example, try switching it up with use, which is a synonym that's easier to pronounce, sounds more natural, doesn't take away anything from your speech. Number 4, the power of silence. Remember, silence is golden. When you're nervous or you forget a word or idea when speaking, you tend to start filling in the spaces between the thoughts, and you start filling in your speech with filler words such as or I personally think that this is a very natural filler and shouldn't be deemed as anything negative if not overused, obviously. But this can be viewed as something very negative, especially in job interviews. Instead, consider taking pauses with brief connected silence. Whether you're looking at your audience or off in a thoughtful manner, your audience will likely think that you're connected to them and will keep their attention waiting anxiously for the next word you say. Last but not least, keep hydrated. I know it might sound silly, but water is an essential component of speaking. Nerves can dry up your mouth, which is why professional public speakers have a glass of water close by if you've noticed during their presentations or any public speaking event and activity. By keeping hydrated, you can prevent your lips and mouth from getting dry, which will prevent from the distractions of your lip smacking or clearing your throat as you speak. Having water handy can be a very good excuse for you to pause, take a minute, take a sip, and collect your thoughts if you need to. So, 3 more tips. Focus outwards, not inwards. What does that mean? Keep the audience in focus. Always think about the audience. Stop thinking about yourself. Take your mind off of yourself and the noise in your head. It helps consider the environment you'll be speaking in. Before you give the speech, try to visualize the audience. How old are they? How many will be there? What will the place look like with them being there? The more you understand all of this, the better you'll deliver. This kind of practice usually takes the pressure off of you. Don't try to make your communication so perfect. The audience is not looking for details you have forgotten. And this is very important, because if you forget, move on. Even great speakers blank out sometimes. The difference is that they have a way back. So the comeback is very important. A short pause, a few steps across or away from the stage, or quiet breaths will all help you make a great comeback. All will help buy you time to reset. Try to avoid saying I forgot or I'm sorry out loud because it starts drawing attention. And just remember to stay composed and keep going instead. So for virtual thoughts, the same goes for any virtual events. Keep your virtual thoughts in order. Zoom and any other online meeting platforms is starting to become the new stage. With the same tips as already mentioned, introduce yourself to the large crowd. There's more fear in person than virtually, so the perfect way is to honor your skills. Remember, eye contact is very critical, even in Zoom. Put a sticky note if you need to next to your camera lens on the computer that says, look here, just to keep reminding yourself. Learn the technology. Practice with your friends and family if you need to, just so you can later on shine when you present professionally. When all else fails, do these 3 things. Stand still, look people in the eye, and smile. These are guaranteed ways to look and feel more confident when speaking, no matter what your topic is, no matter what the setting is. So, step up and speak to help unlock your full potential. Don't hold back. If you feel like you need more practice with public speaking, practice every day through the work you're already doing. So, for example, as medical interns and as students, volunteer to present cases, ask questions during rounds, take the opportunity to speak in front of your team. As residents, make communication part of your daily routine. Explain your clinical reasoning out loud. Don't be afraid to make mistakes. Teach juniors, be a leader for juniors, give clear handovers, and actively seek feedback from your seniors. And if you're thinking outside of medicine, try joining public speaking communities like Toastmasters, for example, is something I came across when making this presentation, or any other speaking clubs, if you know any. They're a great way to build your confidence, sharpen your communication skills, and grow in a supportive environment. So last but not least, public speaking is a skill, not a personality trait. So practice it like one, and it will change more than just your presentations. The more you speak, the more confident and effective you'll become. Your voice is one of the greatest tools as a physician, so try to use it every day. And by this, I'll be done with my presentation. Feel free to ask any questions, share any of your thoughts. I'll be happy to receive any. Thank you.
Thank you so much, Dr. Raghad, for your informative presentation. Anyone wants to share experience or have any question to Dr. Raghad? Feel free.
Thank you so much for very informative, well done presentation. Thank you so much, both presenters.
Thank you, Dr. Nader.
You're welcome. If there are no more questions, we can move on to the next topic.
Okay, so our next presentation will gonna be presented by Dr. Nabiha about the project management principles. So Dr. Nabiha, if you are ready, the floor is yours. You can start.
Hello everyone, this is Nabiha, and today I'll be presenting my presentation on project management principles. So let me start. Just a minute, please. Oh. All right, so first of all, as we begin, we need to understand what exactly is a project. So it's a temporary endeavor with a clear beginning and a clear end. And it has got a clear boundary. And most important thing is that it creates something new that did not exist previously. So some new conclusion, um, some new invention maybe. So this is how we define a project. And to do a project efficiently, we say that we need to go for project management. But we need to understand that why exactly do we need project management, especially in a research project. Since we are so much involved in the clinical research, it's important to understand the role of project management. So it improves the efficacy across the research project. It helps in organization and effective execution of activities and tasks within a given time frame, and it helps us avoid any unnecessary delays and problems. And most importantly, it helps us stick to our goal, so that we are able to finish all of our tasks in the given time period, and there's no excess delays or wastage, um, be it the wastage of time or the wastage of revenue. Now, there are five main principles of project management. These are initiation, planning, execution, controlling and monitoring, and closing. So we are going to see all of these principles in detail. First of all, we are going to start with initiation. So when we say initiation, it's like we are formally starting a project. And now, before we start doing anything else, we need to understand that what we are exactly doing. We get the permission of how to do it and whether we are permitted to do it, and then secure the money to pay for it. So these are the few goals that should be done when we initiate the project, and the study proposal basically deals with all of it. And the key elements, as we see here, are the research question to the hypothesis. So the objectives, the study invention, population and eligibility criteria, sample size, expected differences, data collection and analysis, um, a monitoring plan, reporting, dissemination, quality insurance, quality assurance. So these are the few things that we propose when we initiate the project, and the project management helps us adhere to it and makes it very effective so that the rest of the project can be continued smoothly. Few of the other very important things at the beginning of the project is seek the ethical approval, set up a steering committee. So it's a committee where we have got the principal investigator, and then we've got a chair and independent members, which collectively make a committee and decide whether this project is worth moving forward. Are there any changes or improvement that can be done in the proposal before we continue? And then if there's any funding, so we need to submit these funding applications. Once we are done with the proposal, the next thing is the plan. And the plan is the blueprint of the project. It is the most important principle of the project management. Why is that? Because it deals with the vision, scope, and day to day operations. First of all, when we make a plan, we make a study protocol. So, study protocol deals with the timeline, the milestones, the responsibilities, the communications. When we talk about the timeline, so it is the timeline of when should we start the project, what would be the finishing time of the project, and in between two, we can allocate different time frames to different tasks. So that is very important. And then who is responsibilities would be like what member is going to be responsible for what task. So allocating responsibilities. And then communication is very important because we need to communicate with all the committees in time if there's anything we require. And then the budgeting. So it itemized staff salaries, side payments, and contingency funds. So what are the contingency funds? These are some extra funds that we need to have in case things do not go as per planned. Then the study manuals and documentation. So these are also part of the planning because they standardize the study and the training material that is distributed among all the members. It includes any training manuals, pharmacy manuals. For example, if there are drug trials going on, confidential randomization softwares, and GCP standards. So GCP is basically important for clinical trials. So here, whenever we are going for the clinical trials, there are few documentations that needs to be done. That is patient history, medical records, staff training, lab reports. So these can only are done very effectively if we are doing that in a managed manner. So otherwise, few things can be left alone, few things can be done in a sub standardized manner, which would not be effective. Once we're done with the protocol formation, the next thing is execution. That is the implementation of the plan. And if there's a clinical trial, we're now going to carry out the trial. So, first of all, we need to acquire and develop teams. So, now we are going to distribute all the tasks to different members. So, we need to make teams which are efficient and effective. We need to allocate resources to them. Again, we have to do quality assurance. Project management is also very important because throughout the project, it ensures the quality of the project as a whole as well. And then deliverables, like whatever resources or re- um, things that are needed in order to carry out the project is given to the teams. Then communication with the stakeholders, like any fundraising funders, any regulators, participants, teams. And then conduct the research. So any sample analysis, data processing, all of these are part of the execution, and all of these need proper management so that they're done in a regulated, smooth manner and on time. And most importantly, within the time frame that we have allocated for them and the resources that we have decided. Again, it is important to understand that it helps us eliminate any wastage of resources or the time. And then disseminated educational resources. So any educational resources that need to be distributed, or you think that would help further in the execution of the project, would also be distributed during the execution. Now, with the execution is an important thing, that is controlling and monitoring. So process occurs alongside the execution, and it measure progression and performance versus goals and timelines. Like how much of the progress has been done, how much project milestones have been achieved versus the goals that had been set initially and the timelines that had been initially set. So it's very important to have a good monitoring system. All right. So monitoring and audits, medical records, reviewing manuals and SOPs, ensuring GCP compliance. We have already learned about GCP previously, the important components of the GCP that need to be looked at. And then when we talk about monitoring, it's all about reviewing everything and ensuring that everything is according to the standards and no substandardized documentation is there. Review milestone task, data management, checking for any errors, interim analysis, and safety monitoring. So it's very important to ensure the safe space throughout the project, and controlling and monitoring ensures that outcomes compared to the plans and adjustments are made. So if we need to speed up some process, we would do that. If there are any other adjustment that need to be made, that would be made in order to reach to the goals that we have initially decided, and in order to ensure that our project is completed on time as well. Again, contingency plan is risk assessment, potential impact, and recommended action. So all of these include the scenario in which the things are not going according to the plan that we had initially thought of. And then the closing. Now we are towards the end of the project, so we are going to look at the final data analysis, report the data, presentations, manuscripts in peer-reviewed journals, close the study sites, inform ethical committee and staff, submit the final funding reports, inform the study participants of the outcomes, and archive records in accord with the ICA GCP guidelines. So, all documents kept for at least 3 years after the completion. So, we need to close everything properly so that there's nothing open ended that is left, and project management ensures that. So, from initiation to closing, project management ensures that everything is done in a very regulated and ordered manner. Tips for overcoming the challenges of the project management. So, first of all, it's very important to define the project scope. We need to be very clear when we define the scope, which includes all our goals, objectives, and deliverables. Develop our project timeline, create a detailed project timeline, identify the milestones, milestones that will help us achieve the objectives of the project.
Dr. Nabiha, your voice is kind of cut off. Can you try to test your mic again?
And contingency plans to address them. Use project management tools. Consider using tools such as Gantt charts, project management software, and risk management tools. So, these are basically all the tools that will help us eliminate the errors, identify the errors on time, and then make adjustments on time so that everything is completed as per plan. So these are the two successful projects which specifically use the project management principles. These are the obsessive compulsive treatment efficacy trial funded by NIHR and alcohol and pregnancy project. These were successful, and the team members found out that using these principles of project management, they were able to do everything very efficiently, effectively, and there was very less wastage of resources. Everything was done within time. And the project satisfaction towards the end was also good. So, this proves that project management truly helps with better outcomes of the project. This is a reference that I used, and thank you. If anyone has any question, I'll be happy to answer.
Thank you so much, Dr. Nabiha. Anyone want to share any experience or have any question to Dr. Nabiha?
Thank you so much, Dr. Nabiha, for also great presentation and excellent topic. I think this topic might be far from what we are taught in medical school and in practice. And the issue is when you start working as a resident, or when you graduate, become a specialist, for example, you will come across some sort of administrative task, and if you are learning these tools, learning these skills from early stages, like the time now you are being, I think it will help you address some of the future goals or tasks that you will come across. I'm gonna share my experience. I was involved in writing a paper, but to write the paper, we started working with some older adults, let's say. So the idea is to collect their respective or their experience or their challenges or their look at what and how they use technology. So basically, we needed to do a questionnaire, but not in a questionnaire format. We did it in a group, like a small group discussion, and then obtained all their input. And we did this in 2 phases, 2 sessions, and 2 places, 2 group of participants. So if we have a good skill like what Dr. Nabiha mentioned, then we would have been arranging everything for the project from A to Z, like what we're gonna do and this and this. But at that time, we did not have any skills of project management. Another physician and I were the responsible. So we just asked some of the secretary that work with us to help us, and then approach the community, and then did that. So it's just spontaneous. We did not put it in timeline, and we ended up collecting the data. The next phase was how we can report this as a paper or write this and submit it. So we created a different team to work on this paper using this data that we collected. And when we are done writing the whole manuscript, I was the one who tasked with submission. So I submitted to one of the journals. And I did not know that you're supposed to pay like 3,000 for the article to be published. I'm like, oh, we did not think about that in advance. But in any way, I paid, and then I came to the team and I told them that the challenge that we faced, and they helped with that. So this is supposed to be from the very beginning. We thought of planning ahead of how we can secure this like funding, as Dr. Nabiha mentioned, how we can put every step on the way, the task divided into the teams, so who will do what, and then the timeline, so that we can achieve complete the project in a timely manner, instead of doing it slowly while we are working on other stuff. So I think it's important to know the basics of how to handle the project. The project can be a simple one, like if you want to write just a case that you can present in a conference, or you can make a research project like a systematic review. You want to make a poster out of that, so you collect the people, the team, identify the task, divide it, and then timeline, so that you can meet the deadline for a conference, for example. And if accepted, how you can handle the fees for the registration and presenting there, printing the stuff and the poster and so on. So in actuality, you may need some of these skills in your activities while you are here in the TGRF program. Thank you so much again, Dr. Nabiha. if any one of you wants to share their experience, their perspective in this area, please feel free.
Thank you so much, Dr. Nadir, for sharing your valuable experience. Literally, that's very helpful, and that really tells us how project management is so important, especially in our field of medicine and clinical research.
Thank you so much, Dr. Nabiha. Thank you so much, Dr. Nadir, for your experience. Anyone want to add his experience also? Okay, if no one, let us move to my presentation. Let me share my screen. Wait, sorry. Is it clear?
Yes, we can see your screen.
Okay. So, hello everyone. Today I will be presenting a practical topic that is highly relevant to the most every systematic review team, which is how to manage study screening effectively using Rayyan. As many of us know, searching databases is only the beginning of a systematic review. The real challenge often starts after we retrieve hundreds of even thousands of records that must be organized, deduplicated, screened independently, and documented carefully. So during this presentation, I'll explain what Rayyan is, what it fits within the systematic review workflow, how to use its main features, and how its AI tool can support screening without replacing human judgment. I will share practical recommendations that can help teams make the screening process faster, more consistent, and more transparent. Before we explore Rayyan, we first need to understand the problem it's designed to solve. In many systematic reviews, screening becomes the main bottleneck. A broad database search may retrieve thousands records or more, as we know, and every title and abstract must be assessed carefully against the predefined eligibility criteria. So this workload is effectively doubled because the label study selections uses requires two independent reviewers. Each reviewer screens the records separately before disarrangements are identified and resolved. When this process is managed manually through spreadsheets or long email chains, it can take several weeks. It may also create practical problems such as duplicated work, inconsistent decisions, multiple file versions, and difficulty tracking who is screened each study. So the good news is that specialized screening software was significantly reduced this burden. In Rayyan's original validation survey, users reported an average reduction of approximately 40% in screening time, and around one-third reported saving more than half of time they would normally spend. So Rayyan does not remove the need for human screening carefully. And instead, it helps researchers organize the process, collaborate more efficiently, and spend less time managing record manually. So now we understand the screening problem, not exactly where Rayyan fits within the complete systematic review workflow. So what's Rayyan first at the beginning? Rayyan is a free to start AI-powered web and mobile platform developed specifically for screening studies in systematic scoping and other literature reviews. It was originally developed at Qatar Computing Research Institution and was validated in a peer-reviewed study in 2016. Since then, it has become one of the most widely used screening tools in evidence synthesis. One important advantage is that Rayyan is a web-based, mobile-friendly, and cloud-based. This means reviewers can screen studies from different locations, and the mobile application can also support offline work before synchronizing the decision later. So Rayyan is also designed for team-based research. Multiple collaborators can work within the same review while having clearly defined roles and independently screening decisions. From a methodological perspective, the platform supports key systematic review requirements, including dual independent screening, documentation of exclusion reasons, and Prism compatible exports. Rayyan also was launched in 2016, offers a free tier with additional paid AI features, supports several review types, including systematic, scoping, umbrella, report, rapid and narrative reviews, and can manage very large libraries containing more than 100,000 records. It is now used by hundreds of thousands of researchers globally. So Rayyan, it's not simply a storage platform for references, it's a dedicated screening environment that helps research teams organize decisions, maintain independence, and document that the study selection process clearly. Where Rayyan fits in your review pipeline. The first stage is identification. At this point, researchers search databases such as PubMed, Embase, Scopus, then export or retrieve references. The second stage is duplication, because the same study may appear in several databases, as we know. So the combined library must be checked and duplicate records removed. The third stage is title and abstract screening. So two reviewers assess each record independently against the predefined eligibility criteria. So Rayyan supports blind screening, so neither reviewer is influenced by others' decision. The fourth stage is full text screening. Potentially illegible papers are retrieved in full and reassessed carefully. Any excluded full text article should be assigned a clear and specific exclusion reason. So the final stage is synthesis, which include data extraction, risk of bias assessment, meta-analysis when appropriate, and preparation of Prisma flow diagram. So Rayyan is the strongest in the middle of this pathway. Duplication, title and abstract screening, and full text screening. These all are usually the slowest or most error-prone parts of the review. It's important to understand that Rayyan does not conduct the database search or the statistical synthesis. It creates a clean bridge between them. We can import records from databases or reference managers, complete and document the screening process, and then export the final decision to tools such as EndNote, Excel, Confidence, or RevMan. So Rayyan helps us control the section of workflow where research terms most likely to become overwhelmed by large numbers of records and conflicting decisions. So we know where Rayyan fits within the review workflow. Let's look at the main features that make it useful during screening. The first feature is smart duplication. Rayyan identifies records that may be duplicated across different databases, export by comparing details such as titles, authors, publication years, and identifiers. These records can be reviewed and resolved efficiently. So the second feature is blind screening mode. While blind mode is active, reviewers cannot see each other's decisions. This helps maintain independence and reduce the risk that one reviewer votes will influence another. The third feature is AI relevance rating. As reviewers make include and exclude decisions, Rayyan learns from those choices and predicts which remain records are most likely to be relevant. So these predictions can help prioritize the order of screening. The fourth feature is keyword highlighting. Important inclusion terms can be highlighted in green, while exclusions-related terms can be highlighted in red. This makes key information easier to identify while reading titles and abstracts. The fifth feature is the use of labels and exclusion reasons. Researchers can create standardized categories such as wrong population, wrong intervention, or wrong study design. So consistent labels improve team communication and make PRISMA reporting easier. And finally, Rayyan provides useful filters and export options. So records can be filtered by decisions reviewer, labor, or relevance rating, and the results can be exported to formats such as RIS, EndNote, or CSV for the next stage of the review. So together, these 6 features help make screening faster, more consistent, we can say, and easier to document. So the platform remains a support tool. The quality of the final decision still depends on the clear eligibility criteria and our careful judgment. So let's move to the practical steps. First, I was going to explain, and then after the finishing the slides, I was going to show you one by one and open Rayyan. So our first step is to create the review correctly and import the search results in an organized way. This stage may appear simple, but mistakes here can affect the screening counts. So the audit trail and the final PRISMA flow diagram also can be affected. Step 1, we should sign up and create the review. First, go to the Rayyan AI, create an account, and select New Review. Give the review a clear and specific title. The title should allow every team member to recognize the project immediately, especially when they are involved in several reviews at the same time. And then next, select the appropriate review type, such as a systematic review, a scoping review, or umbrella review, or a rapid review. And then add the research question and a short description of the project. This description should briefly explain the population, intervention or exposure, comparator, and outcomes where applicable, which is our PICO. It's also useful to include the protocol registration number to project identifier in the description so that the review remains linked to the approved methodology. And then after completing the database search, export the retrieved citation from each source. So this source may include PubMed, Embase, Scopus, Web of Science, or any other database included in the search strategy. So it's up to you. So each database should be exported separately rather than combining everything before uploading. So this is important because Rayyan can preserve the source of each record, and the number retrieved from every database is required when completing the identification section of the PRISMA flow diagram. So the original file should be saved in a clearly labeled project folder. For example, like if it's a PubMed, from PubMed, using should be like PubMed, and then data search it, and then number of records. So this project, the audit trail, and make it possible to verify the search results later. And then step 3, upload the references. Rayyan accepts several common citations formats, including the RIS, EndNote, BibTeX, or CSV, or even so the PubMed XML. So upload the files one by one and label each upload according to database source. And then after every upload, confirm that the number of important records matches the number exported from the database. This simple check is essential because a mismatch may indicate an incomplete export or unsupported files, or we can say duplicates uploads or formatting problems. So Rayyan can manage multiple files within the same review while maintaining information about where each record came from. And then step 4, invite the research team. Once references have been imported successfully, invite the co-reviewers using their email addresses. So each team member should be assigned an appropriate role, such as reviewer, we can say collaborator or viewer, according to their responsibilities. So before screening begins, confirm that everyone can open the review, access the records, and understand the assigned tasks. It's also important to agree on who will perform title and abstract screening, who will resolve conflicts, who will manage duplicates, and who will supervise the final decision. So clear role assignment prevents confusion when several reviewers speaking work simultaneously. So before you import, look the protocol first. There is a one critical rule before anyone begins screening. The protocol must be finalized first. The inclusion and exclusion criteria should be written clearly using a framework such as PICO, population, intervention, comparator, outcomes, and study design. So the review protocol should be registered in Prospero when eligible. Rayyan can make screening faster, but it cannot correct unclear eligibility criteria. So we should pay attention to this point. If the criteria are vague, reviewers will interpret them differently, disarrangements will increase, and the final study selection may become inconsistent. Therefore, the platform supports methodological quality, but the protocol creates that quality. And before full screening begins, the team would test the criteria as a small sample of approximately, we can say, 30 to 50 records. Every reviewer screens the same sample, then the teams compare decisions and discuss any unclear points. Only after the criteria are understood consistently should the remaining records be divided for independent screening. After creating the review, importing the database files, and confirming the team rules, then we should remove duplication. This step must be completed before title and abstract screening begins. When we search several databases, the same study is often retrieved more than once. For example, one article may appear in PubMed and also appear in InPage, or we can say in Web of Science. If these repeated records are not removed, reviewers may screen the same study several times, and the final screening count will become inaccurate. So, searching multiple databases commonly creates substantial overlap. Sometimes we can say from 20 to 40% of the complete library. So duplicate records can cause several problems. They increase the screening workload. They will receive different decisions from different reviewers. So the distort the number of records reported in the Prisma flow diagram. So our results are not going to be accurate. They can also create confusion during full text screening and data extractions. Therefore, duplication is not simply to be considered as administrative task. It's essential part of producing a clean and transparent review process. So, before searching for duplicates, first confirm that all database files have been uploaded successfully. And then the number imported from each database should match the number originally exported. For example, when the search retrieves 500 records from PubMed, 700 from Scopes, and 600 from InBase, the initial combined library should contain approximately, we can say, 1,800 records, if we submit all our records. So before duplicates are removed, we should ensure we have all 1,800 records before we click to remove duplications. This original database count must be saved because they will later appear in identifications section of the Prisma flow diagram. And then, after all records are present, open Rayyan's duplicate detection section. Rayyan's will gonna compare several bibliographic elements, including like article titles, authors' names, publication years, journal information, digital objects, we can say, or DOIs, other available citations details. It then groups records that appear to represent the same duplication and provide a similarity estimate. And then we can then it will gonna interpret the similarity results. So, for example, if we have efficacy of a drug X in adults, for example, RCT published in PubMed in 2023, and we have another study, it's also about the efficacy of drug X, for example, in adults, it's RCT published in InPace in 2023. Rayyan may classify these records as approximately 95% similarity because the titles, year, and study details are almost identical. So these are highly likely to be duplicated records. So the third example for drug X in adult patients, pilot study published in Scopus in 2022. This may receive, we can say, 82 similarity rating. So although the topic is related, the different title year and study design may indicate that it is a separate publication. Therefore, the similarity percentage should guide the reviewer, but it should not replace manual confirmation. And then we have to resolve duplicates carefully. So resolve duplicates, do not automatically delete them. For every high similarity pairs, the reviewer should compare the complete title, authors, publication year, journal, DOI, volume and issue, abstract, database source. When these details confirm that the records represent the same article, one record should be retained and the duplicates removed or marked appropriately. So the retained record should ideally contain the most complete information and abstract. And then we should inspect the lower similarity records. Records below approximately 90% similarity require more careful inspection. Two studies may have similar titles but represent different population, we can say, or different study phases, or different follow-up periods. Maybe a pilot study and a main trial also different. Maybe a protocol and a final publication. A secondary analysis and the same of the same data set. So these records should not be removed unless the reviewer is confident that they are true duplicates. So duplicates not removed automatically. It depends on your decision. So you should review when there is articles have high similarity. We should review it carefully and select if it should be removed or one of them it will gonna be added and continue to be added to the next step of the title and abstract screening. And then one particularly important issue is what I call conference twins. A study may first appear as a conference abstract and later as a full journal article. These records can look very similar because they have the same or similar title, the same authors, the same intervention, the same patient sample. However, they are not always treated as simple duplicates. The conference abstract may represent an earlier report, while the full article may contain complete methods, results, and follow-up data. So the team should therefore determine whether they are truly the same report. The full article replaces the abstract and both contain unique relevant information, or they should be linked as multiple reports of one study. So this decision should be made accordingly to the review protocol. And after completing deduplication, document the exact number of duplicates records removed. So this numbers appears in Prism 2020 flow diagram under duplicates records removed before screening. For example, if we have 1,800 records were imported, and then we have 400 duplicates were removed. then 1,400 unique records should remain for title and abstract screening. So these numbers must remain internally consistent through the review. And before reviewers begin voting, perform a final. We should perform a final check. Confirm that all intended databases were imported, duplicates group were reviewed, the number removed was recorded, unique records remain available, no screening decisions were made prematurely, the library is ready for independent screening. So ideally, one designated team member should manage the deduplication process to prevent inconsistent deletion decision. So important methodological point, we should pay attention to it, like duplications should be completed before screening begins. If reviewers start voting before duplicates are resolved, the same study may receive several decisions. This can create incorrect agreement rates, unnecessary conflicts, and inaccurate screening counts. Therefore, the correct sequence is import first, import your files or your data first, and then deduplicate second, and screen third. So Rayyan helps identify probable duplicates quickly, but the researcher still makes the final judgment. So the software detects similarity. The reviewer confirms whether the records truly represent the same publication, and careful deduplications protect the integrity of the screening process and ensure that the Prisma numbers are accurate from the beginning. And then we will move to the central activity in Rayyan, which is the title and abstract screening. At this stage, every record is assessed against the predefined eligibility criteria. The review reads the title and abstract, then assigns one of three decisions: include, maybe, or exclude. These decisions may look simple, but they must be applied consistently, because the purpose of title and abstract screening is not to prove that a study is definitely illegible. No, it's to identify studies that may be illegible and should therefore proceed to full text assessment. So before screening begins, anyone starts screening, the team should confirm that the protocol has been finalized, the inclusion and exclusion criteria are clearly written, the reviewers understand how each criterion should be applied, a pilot sample has been screened by the team, standard labels and exclusion categories have been agreed upon, blind mode is active when two reviewers are screening independently. If these steps are not completed first, reviewers may interpret the same abstract differently and create a large number of avoidable disarrangements. First, decision include. We select include when title and abstract appear to meet the eligibility criteria, or when there is reasonable possibility that the study is relevant. So here just we are make our decision depend on the title and abstract, not full text. We will gonna include title and abstract appear to meet our eligibility criteria. At this stage, reviewer does not need complete certainty. Just for example, like abstracts are often incomplete and may not report every methodological details. Therefore, when an important eligibility certain is unclear, but the study may still qualify, it's usually safer to retain the record for the full text assessment rather than exclude it prematurely. Because here just we are depending on the title and abstract, but we do not have full text screening. When we will move to the full text screening, then we will gonna confirm. We will gonna read the articles with all details, and we're gonna look to the all eligibility criteria there, and then we will decide if this study will gonna go with us after the full text screening or not. For example, suppose our review includes studies of adults aged 65 years and older who present to emergency care. For example, if the abstract clearly states that the populations include elder adults in an emergency emergency department. A report, a relevant outcome, we would select include. Even if the exact main age is not reported, we may still include the record at this stage if the population appear potentially illegible. Okay? So the important point here, we do not exclude a potentially relevant study only because the abstract is incomplete. This is the main important point. Our decision may be we use when the available information we can say is insufficient to make a confident decision. For example, the abstract is not clearly reports the age of the participants, we can say, or the study setting, or intervention or exposure. The exact study design, we can say, or whether the required outcomes was measured. So maybe it's useful because it prevents certain studies from being excluded too early. However, maybe category should not become a permanent storage area for difficult records because every maybe decision must eventually be revisited, discussed, or resolved before the review moves to the next stage. How we have to manage maybe? Reviewers can add a short note explain the uncertainty. For example, age group unclear, emergency setting not confirmed, maybe conference abstract, study design not reported. For example, these notes make the later decision more efficient when the team can immediately see why the reviewer was uncertain regarding this abstract. And important practical rule, if a record remains uncertain after reviewing the title and abstract, it's generally better to move it forward to full text screening. Full text screening is the stage where the final legibility decisions should be made using complete information. And third option is exclude. We select exclude when title or abstract clearly demonstrates that the study fails one or more one of our eligibility criteria. For example, the study may involve wrong population, we can say, or wrong intervention or exposure, or long health care setting, for example, or wrong outcome, or illegible study design, for example, systematic review or whatever, or a publication type that is not included in the protocol. The exclusion should be based on the protocol, not on whether the reviewer personally find the study interesting. For example, if our protocol includes adult age 65 years and elder, but the study is exclusively conducted in children, it can be excluded confidentiality at title and abstract stage. Similar, if the protocol includes original clinical study, but the record is clearly and we can say editorial letter or narrative review or survey, for example, or systematic review, it may be excluded according to the study design. And we should apply criteria in a consistent order. A useful method is to assess every record in the same order. First, check the population. Second, check the intervention or exposure. Third, check the setting or context. Fourth, check the study design. And then check the outcomes where they are required for eligibility. Following the same order reduces cognitive burden and will gonna help you to screen more consistently. So we should avoid changing like the personal decision process from one abstract to another. And most important point for us, or we can say most useful practical features is keyword highlighting. So we can add important inclusion and exclusion terms before screening begins. So inclusion related terms can be highlighted. So this makes important information easier to locate while reading long abstracts. We can say use, for example, inclusion keywords may represent the target population, the relevant intervention, the healthcare setting, the study design, the required outcomes. So this is based on our protocols. For example, like possible inclusion terms could include older adults, geriatric, emergency department, artificial intelligence, machine learning, hospital admission or readmission. And exclusion keyword, also we can add it and we're gonna help. For example, based on your protocol, even so, for example, pediatric, animal study, editorial protocol, case report, or non-clinical study. So these highlighted words help us focus attention, but they should never be used as only basis for a decision. So a keyword may appear in a different context. For example, an abstract may mention that pediatric study were excluded. Even so, the actual study population consists of adults. So the keyword highlighting should support reading. It does not replace reading. Okay. And then also Rayyan provides keyboard shortcuts. For example, I for include, E for exclude, M for maybe, and so on. These shortcuts reduce the time spent moving and allow experience reviewers to process records more efficiently. When keywords highlighting and shortcuts are used together, experienced screeners may review hundreds of abstracts per hour, depending on the complexity of the topics and length of the abstract. But speed should never come at the expense of accuracy. The objective is not to screen as fast as possible. We have to make consistent, defensible, and reproducible decisions. Most important point is that exclusion reasons are not optional. As team, we should create a fixed set of exclusion reasons before screening begins. For example, like wrong population, wrong intervention, or we can say additional to already existent exclusions comments or exclusions reasons in Rayyan. For example, like adding wrong setting, wrong outcome, or duplicate publication, we can say, or whatsoever. Why we standardized reasons matters? Why? Why already we selected reasons? Standardized reasons improve consistency across reviewers. If one reviewer uses wrong age group, another uses ineligible population, and another uses not elderly, these may all describe the same exclusion criteria. So using one agreed variable, such as wrong populations, creates a clear data sets and make later reporting easier. So consistent labels also help the team identify whether one eligibility criterion is causing frequent disarrangements. If many conflicts relate to study design, for example, the team may need to clarify which designs are eligible. So if we compare the title and abstract screening to the full text screening, it's important to distinguish between the exclusion during title and abstract screening and exclusion during full text screening. At the title and abstract stage, we may use labels to organize decision and understand why records were removed. But at the full text stage, a specific exclusion region must be recorded for every excluded report, because Prisma requires the number of full text reports excluded together with the main reasons. So establishing standard reasons from the beginning creates consistency through the review. And the most important point, do not apply several reasons to one study without a plan. A study may fail more than one eligibility criterion. Agree with you. But for example, it may include the wrong population and use wrong study design. The team should agree on whether to record only the first decisive reason. To use for exclusion as exclusion reason, or assign multiple labels for internal analysis while selecting one primary reason for Prisma reporting. For example, maybe population, intervention, study design, or outcomes and publication type. Whichever method is selected should be applied consistently. We should use notes for difficult decisions. For borderline records, reviewers should add a brief note. The note should explain the uncertainty rather than repeat the entire abstract. For example, include mixed age subgroup data may be available, just as label. Interventions appear relevant but comparator unclear. Maybe secondary analysis of an included trial. Abstract does not confer emergency setting. So these notes became especially valuable when blind mode is lifted and conflicts are discussed. And most important point, we should maintain the blind independent screening. When two reviewers are required, each reviewer should complete the assigned records independently while the blind mode remains active. Reviewers should not discuss individual records during the independent phase unless the protocol itself is unclear. They should also avoid sharing their votes outside Rayyan. The purpose of blind screening is to obtain two independent assessments. If one reviewer sees the other reviewer's decisions first, the decisions may influence their judgment and introduce bias. The most important, do not lift blind mode too early. Blind mode should remain active until both reviewers have completed the screening stage. If it's lifted early, reviewers may see previous decisions while continuing to screen the remaining records. So this will gonna weaken independence and may affect the reliability of the process. So screening should be completed first and the conflict should be resolved afterward, after removing the blind mode. Managing the maybe category before moving forward. This is the most important point. Before title and abstract screen is considered complete, the team should filter all maybe records. Before at the end, when we say maybe, all of us know. Maybe, so that means you are not know. Is this included or excluded? And if it's included, so that means we're gonna move with you. If it's excluded, that no, it will not gonna be with us in our study. But if we remain it as maybe, that means it's stocking. This abstract is stocking. It is not excluded or included. So we should moving maybe, we should managing maybe before moving forward. Either to be include or either to be exclude. So the review should not proceed with a large unresolved maybe pile. So a clean endpoint is important before the included set becomes the group sent to full text retrieval. As all of time told my teams, like, if you are not sure and you feel like this study may be, you can include it. If you include it, another reviewer, your part reviewer, which is actually work as pair with you on the same study, if selected exclude, it will gonna be as conflict. So at the end, we will gonna resolve this. If also include this study, it will gonna move to the next stage of the full text screen. So again, we will gonna review it, and again, we will gonna do the decision to be finally include or exclude. And then the quality control check at the end. At the end of title and abstract screening, the team should confirm every record has been assessed by the required numbers of reviewers. No records remain unreviewed. Maybe decisions have been resolved. Standards labels have been used consistently. Notes are attached to difficult cases. Blind modes remain active during independent screening. And the records are ready for conflict resolutions. So, the common mistakes we should avoid. First is excluding a study because the abstract does not provide enough information in such cases. Use maybe or include and review eligibility criteria, while screening without documenting the amendment. Third is using personal judgment instead of the protocol. Fourth is lifting blind mode before reviewers finish. Fifth is allowing the MAP category to remain unresolved. Sixth is using inconsistent exclusion labels. Avoiding these mistakes makes the screening process more transparent and reproducible. So, from this first part of screening, title and abstract screening, we should uh, we should review, putting in our mind, does it clearly meet the criteria? Include it. It's important information missing, mark it maybe or remove it forward. Does it clearly fail the criteria? Exclude it and apply the appropriate reason. Rayyan makes these decisions easy to organize, but the validity of the process is still depends on our strong protocol, our reviewing as independent reviewers, and consistent judgment. So here, as I mentioned, when we work as team and we have blind mode is on, so we are reviewing independently. So why actually we need two independent reviewers? In a systematic review, study selection should not depend on judgment of only one person. This is most important point, because before moving to full text screening, we should make sure that all studies, all titles and abstracts are screened by two independent reviewers at least. I'm going to show you even so after that in Rayyan how we have to make sure about that, how we're going to check all of our articles, we can say, are screened by two reviewers independently. So two reviewers may interpret the same eligibility criteria differently. One reviewer may notice a relevant population detail, while another one may identify an illegible study design. So independent screenings will help reduce selection of bias, individual oversight, subjective interpretation, accidental exclusion of illegible studies. So our purpose is not to make reviewers agree automatically. No, our purpose here is to obtain two assessments and then resolve any difference transparently. So reviewer A and reviewer B. So reviewer A, for example, a vote include, while reviewer B votes exclude. This does not necessarily mean that one reviewer had a mistake. No, the disagreements may have occurred because the abstract is unclear, we can say, or one criterion was interpreted differently, or one reviewer noted information that another reviewer missed. Maybe the study contains a mixed population, we can say. Maybe the publication type is uncertain. Maybe the study design is not clearly described. So Rayyan records both decisions without revealing either vote while blind mode is active. So the blind mode means what? Means that the reviewers cannot see each other. So reviewer A does not know where the reviewer B selected include or exclude or maybe. And reviewer B cannot even so see reviewer's A decision. So this protects the independence of each reviewer. So why this matter? Because since another reviewer's vote can influence a decision's even. So for example, a reviewer may initially think that a study should be excluded, but after seeing the another colleague included it, may change their decisions without independently reassessing the eligibility criteria. So blind screening reduces this influence and ensures that both decisions reflect each reviewer interpretations of the protocol. So what reviewers should do during the blind screening? While blind mode is active, each reviewer should apply the same criteria. Complete all assigned recorded independently. Use agreed include or exclude options. Add short notes for difficult cases. Use the standardized labels and avoid discussing individual records before completion. And never turn blind mode off too early, as I said. And when the screening ends, blind mode will gonna be turned off. So once both reviewers have completed all assigned records and the blind mode turned it off, Rayyan then reveals the decisions and automatically identifies agreements and disagreements. So agreements may include it, post reviewer selected include, or post selected exclude, or post selected maybe. And conflicts may include versus exclude, or one reviewer selected include and one reviewer selected maybe, so it will gonna be conflict. When selected exclude, when selected maybe, will gonna be conflict. When selected include and when selected exclude, also will gonna be conflict. But the most important, or we can say conflict, most important for us, when someone select include and another select exclude, because here we should do decisions, assert decisions, because here we have two separate decisions of the two reviewers. So, and then our filters to conflict. Rayyan allows the team to filter the library and display only conflicting records. So instead of reviewing the entire database again, the team can focus directly on the studies that requires discussion. For each conflict, reviewers should examine title and abstract, again, the relevant eligibility criteria, the label selected, any notes added during screening, the reason for disagreements. So no need even so to go for the, we can say the all articles included in the title and abstract screening. No, in title and abstract page, we're gonna select the filter of conflicts. The number of conflicts will gonna be appear. So we're gonna see all title and abstract there. So again, we're gonna assess title and abstract, a third reviewer to resolve this conflict. We're gonna review the title and abstract. We're gonna read the labels selected by the previous reviewers, and also if any notes was added by the previous reviewers, and the reasons why both reviewers disagreement with this title and abstract, and then take a look to the relevant eligibility criteria, and then with all of attention make the third decisions, and then the conflicts will gonna be resolved based on his decision. So reviewers to discuss each this arrangement systematically. And this is most important point. And the protocol is very free. So during the conflict resolution, the strongest opinion should not determine the outcome. The protocol here should act as the referee. So, for example, who is correct? The correct question is, which decision is most consistent with the predefined eligibility criteria? It's not about who is correct and about who is wrong. No. Here we are talking about which article should gonna be added with us and go for the next step or the full text screening. So we're gonna ask which decision is most consistent with predefined eligibility criteria. So here we're gonna use the third reviewer. And then third reviewer will gonna be document the final decision. So when a study is excluded, the appropriate label or reason should also be attached. And difficult cases may require a short note explaining why final decisions was made. For example, included because subgroup data for adult age 65 years and older were reported separately. Excluded after third reviewer assessment because participants were exclusively from outpatient clinics. So this will gonna create a transparent audit trail. And the most important point is resolving MAPE decision. MAPE decisions also need to be resolved. So a study cannot be remain permanently in MAPE category. As I told you, if we remain this study in MAPE, that means study is stucking. Okay, so we should discuss each MAPE record either to be include or exclude. To be progress, we can say to full text review if urgently to remain. So when an abstract does not contain enough information, the service methodological decision is often to retrieve this full text rather than exclude the study permanently. Because in the next step, we will gonna read all articles and depend on the full text to either include or exclude. Maybe some information missed, information related to our eligibility criteria missed in the abstract, but find it again in the full text screening. So measuring the reviewer agreement. Once the decisions are exported, the team can calculate reviewer agreement. So simple percentage agreement shows how often reviewers selected the same decisions. So we have formal measure is kappa, which is considers agreement P1 chance. So low agreement does not automatically mean that reviewers perform poorly. No, it may indicate eligibility criteria are unclear. The topic is complex. The reviewers need additional training. The pilot screening stage was insufficient. So the agreement should therefore be used as a quality improvement indicator, not other else. The importance of pilot screening before screening the full library. Both reviewers should assess the same small sample around, for example, 30 to 50 records. So the team should compare decisions and identify the main sources of disagreements. For example, is the age threshold clear? Are mixed population eligible? Are conference abstract include? Are retrospective studies eligible? Does the outcome need to explicitly reported? So if the team, for example, assess a small sample, 3 to 50 records, we're going to ensure about all these points. So the criteria will going to be refined before full independent screening begins. And this step will going to help us to reduce the later conflicts. And the common conflict resolution mistakes, which is very important point to pay attention on it. First is listing blind mood before post reviewer finished. And second is allowing one reviewer to change decision simply to match the other. And the third is resolving conflict from memory without reopening the abstract or full text. The fourth is make decisions based on the personal preference rather than the protocol. And the fifth is failing to the document while a difficult study was included or excluded. And the sixth is to changing an eligibility criterion during screening without recording a protocol amendment. Okay, here we should know also the AI advantage. Systematic review also may contain thousands of records, but only a small portion may ultimately be illegible. So the challenge is similar to searching for a needle in high stakes. So Rayyan's AI does not make the final illegible decisions. Instead of that, it helps organize the high stakes, so the potential relevant studies becomes easier to identify. So 5-star relevant ratings. After reviewers complete a number of screening decisions, approximately 50 decisions in the example shown in Rayyan begins learning from the patterns in those decisions. It examines the characteristic of records that were included and excluded, then gives the remaining unscreened records a relevance rating. So the records receiving higher ratings are predicted to be more similar to the studies already included. So the team can then sort records by rating, allowing likely relevant studies to appear closer to the top of the screening list. So this can be useful because reviewers can focus their attention and energy on records that are highly probability of illegibility. What the rating does not mean, 5 stars rating does not mean that the study must be included. And also, similarly, a low rating does not automatically mean the study is irrelevant. So the rating is only a prediction based on information available and in the citation and abstract, as well as the decisions previously made by reviewers. So every record still requires our decision according to the protocol. And then there is AI searching. These features may assess relevance using the illegibility criteria before a large number of manual decisions have been made. So the AI may begin prioritizing studies directly from the review questions and inclusion criteria. It may also provide features described as an AI reviewer or support automated extraction of selected information. And these features may improve efficiency, but they should be treated as research assistant, not as replacement for trained reviewers. Continuous re-ranking, this is another advantage. So as reviewers continuing screen, Rayyan receives more information from every include and exclude decision. So the relevance predictions can therefore update continuously. And early in the screening process, the model has limited information. Later, after more decisions have been made, the ranking may become better aligned with the reviewer's illegibility pattern. And also the golden rule. The most important point here is AI prioritizes the order of screening, and reviewers still make every include or exclude decision. So this distinction is essential, and Rayyan may help decide which study we examine first, but the software should not independently but not should be the main reviewers. So because AI may misunderstand complex study, we can say mixed population, subgroup illegibility, unclear abstracts, multiple reports from the same study, clinical terminology used in different contexts. So as reviewer, as human reviewer, we can interpret these details using full protocol and methodological judgment, but AI may misunderstand that. Report AI used transparently. Any use of AI should be reported clearly in methods section. So the research team should explain which AI features was used and at which screening stage was used, even whether it was used only for prioritization, whether any records were excluded automatically, how many oversight was maintained. So transparent reportings allow readers and journal reviewers to understand exactly how the study selection process was conducted. Rayyan's AI can reduce cognitive burden and improve the order in which records are screened, but the methodological responsibility remains with us as team, and AI will help us navigate the evidence more efficiently, but does not replace the critical appraisal or our accountability. So then, after we completed the title and abstract screening, we should move to the full articles, or we can say the full text screening. So these stage are especially important because they produce the final set of included studies and the numbers required for the Prisma flow diagram. After title and abstract screening, all potentially illegible records, we're going to move with us to the full text assessment. So here, at this stage, our team will going to retrieve the complete article and checks every illegibility criterion in detail. So we should organize this phase in different ways. Some create, for us team, I'm talking as team, some create a separate review for full text screening. Others keep the records in the same review and apply labels indicating that the articles has reached the full stage. Whichever method is selected, the process should be clear and consistent across the team. We should attach the same PDF when possible. Attach the PDF to the relevant Rayyan record if it's possible. This will gonna help ensure that every reviewer assesses the same version of the article. It also avoids confusion when several reports have several titles, have similar titles, or when preprints and final publications both exist. So, reapply the full eligibility criteria. At full text screening, the reviewer should assess also population, intervention or exposure, comparison, outcomes, study design, setting, publication type, and any additional protocol-specific criteria. Unlike title and abstract screening, the full article should provide enough information for a final decision in the most cases. And then we will gonna continue independent screening. When the protocol requires 2 reviewers, full text screening should also be conducted independently. And again, applied mode should remain active until both reviewers have completed their assessment. And also conflicts should be discussed and resolved using the same process applied during title and abstract screening. And every export excluded at the full text stage must have a clear reason. Either wrong population, wrong intervention, wrong study design, or we can say relevant outcome not reported, conference abstract only, full text unavailable, duplicate report, insufficient data. So the reason should be specific enough to explain why the report did not meet the protocol. And we should choose the primary reason. So a paper may fail more than one criteria. For example, it may involve the lung population and also report an illegible outcome. So here you should use an agreed reason and record the fairest, decisive, or primary exclusion reason. So this will gonna prevent double counting in the Prisma flow diagram. And Prisma reporting, these reasons later appears in Prisma 2020 section. So reports excluded with reasons. Therefore, careful documentation at the time of screening saves a significant amount of work while writing the manuscript. And then we in SFR, we're going to export and report. Once screening and conflict resolutions are complete, the final decision should be exported. We're going to export available record sets. So Rayyan allows the team to export included studies, excluded studies, undissolved records, records with particular labels, reviewer decisions, exclusion decisions. And the common export formats can be either CSF, PIPTEX, EndNote, and ARIS. So, and CSF is most especially useful because CSF file can preserve detailed information, including individual reviewers' votes. So this allows the team to review disagreements, check screening completeness, and calculate agreement statistics, prepare an audit trail, save a backup for the project. So reviewer agreement can be assessed using percentage agreement, or we can say kappa when appropriate. And they populate the Prisma flow diagram. The team should confirm the number of records identified, duplicate records removed, records screened, records excluded in title and abstract state, reports sought for retrieval, reports not retrieval, full text reports assessed, reports excluded with reasons, studies finally included. Because all these counts and then used to prepare the Prisma 2020 flow diagram. And then we're gonna move the included studies to the next tools. So, and Rayyan, we're gonna remain the main role in screening. After the included studies are finalized, they may be transferred to another tool for data extraction, risk of bias assessment, evidence tables, statistical analysis, meta-analysis. So these tools may include Excel, Confidence, RevMan, R, Stata, or another platform selected by the team, and export early and keep backups. So the team should not wait until the very end to export the data. So regular CSF backups are recommended through the project. For example, a weekly export can preserve screening progress, reviewer decision, labels, notes, exclusion reasons. So from this slide, the most important point is full text screening determines the final decisions included evidence. Exporting preserves how those decisions were made. Together, these steps transform the screening process into a transparent and reportable evidence trail. So, if we compare Rayyan, Rayyan is not the only platform available for evidence screening. So we compare it to two commonly discussed alternatives, Confidence and AS Review. The purpose is not to claim that one tool is perfect for every review. So the best platform depends on the project's budget, team structure, methodological needs, and technical experience. So Rayyan cost offers a free tier, while some advanced AI functions requires a paid subscription. For example, if you want to use it for the data extractions, need unpaid subscription. If you want to use AI features or AI advanced to help you for prioritizing the studies and so on, this also need paying subscription. And also, if you want to use it for risk of bias assessment, also this need a subscription. And if you want, for example, use it as tool for meta-analysis, this also need paying and also need an institutional access. So this makes it accessible for student-led, fellow-led, and we can say low-budget research teams. So for screening, till full text screening is very helpful as free tool. Confidence is generally a paid platform. So although some universities and institutions provide license, so Confidence needs even some institutional access from the beginning, from the title and abstract screening. AS Review is free and open resource. And regarding the scope, Rayyan mainly specializes in deduplication and study screening. It's particularly strong in the middle stage of systematic review. So Confidence offers a broader workflow that may include screening, full text management, data extraction, and risk of bias functions. And AS Review focuses mainly on active learning, assisted screening, and study prioritization. And team screening, Rayyan supports collaborative screening and blind reviewer decisions. So this makes it useful for research teams working across different countries or institutions. But Confidence also provides strong team screening functions and is commonly used in coherence style reviews. AS Review is powerful for active learning, but traditionally multi-reviewers workflow may be more limited or require greater methodological planning. Best use cases. Rayyan is best suited to team seeking fast screening, low cost, blind collaboration, simple learning curve, and AI-assisted prioritizations. But Confidence may be more suitable when the review has institutional funding, The teams want one platform for several review stages. A structured, coherent style workflow is required. AS review may be most useful for methodologists, data scientists, researchers interested in active learning, team comfortable with more technical or Python-based workflows. So I added these slides because I noticed a lot of doctors, you can say, have an idea. I want to start their systematic review, but they stopped because, for example, they want to use confidence because it's managed more easier. Or we can say, and at the same time, confidence in institutions. And this led them, you can say, to either stop doing their project or even so to postpone it to find institutional access. Despite they can starting their project, saving their time, starting with Rayyan, doing the title and full text screening, and then export for the and then export studies, doing data extractions and finalize the results. So for us, as a fellow-led systematic review without dedicated software budget, we can say Rayyan is often a very strong starting point. It provides us with the essential features required for organized and independent screening without forcing the team to complete review management package. So it can also work alongside other platforms. For example, a team may use Rayyan for screening and Excel for data sheets, and RevMan or R for meta-analysis. So choosing Rayyan does not lock the team into one software ecosystem, we can say. So this slide summarizes practical habits that can improve both the speed and quality of study screening. They are not simply shortcuts, we can say. Some protect methodological rigor, while others improve team productivity and project safety. Okay, I'm sorry, just wait 1 minute by closing the screen. Okay, first habit is to finalize the protocol before the first screening vote. Rayyan can organize decisions, but it cannot compensate for unclear criteria. So our PICOS framework and all eligibility rules should be agreed upon before screening begins. So protocol should be registered in Prospero when the review is eligible for registration. The second is pilot shift together. So before dividing the full library, all reviewers should screen clarification sample together. So we should ensure that at least 2 reviewers, 1 article reviewed by 2 reviewers at least. A sample of approximately 30 to 50 records is often practical. We can use it at the beginning. So the team should compare decisions and discuss that the protocol inclusion and exclusion criteria is clear, unclear population, if there is any mixed age groups, if there is illegible study designs, if there is any conference abstract, outcomes, if there is a difficult publication type. So the criteria should then be clarified before independent screening begins. And blind mode should remain active until both reviewers complete their assigned records. And lifting the blind mode early exposes reviewers to each other's decisions and weakens the independency. So the correct process is independent screening first, and then consensus second. And then Rayyan's keyboard shortcuts and keyword highlighting can improve efficiently. So the keys inclusion and exclusions and maybe, so it corresponds to including exclusions and maybe. So green and red keywords highlights can make relevant information easier to identify. So this feature should support careful readings, not replace it. And when AI relevance ratings become available, likely illegible records can be moved towards the top. So this allows reviewers to process the most promising studies while their attentions and energy are strongest. So all records must still be handled according to the protocol unless the review methodology has formally justified another approach. And then the mobile application can make screening more flexible. So short periods of available time during travel, breaks, or waiting periods can be used to make progress. So offline mobile screening may also be used when internet access is unstable, with decisions synchronized later. So reviewers should still avoid rush decisions when the abstract is complex. And then regular exports act as both backups and audit records. So a weekly CSF exports can preserve decisions, notes, labels, exclusions, reasons, reviewer progress. So the file name should include the review title and export date. So for example, Rayyan review backup 8 July 2026 CSF. Like the title should be very clear. So this makes previous versions easy to identify. So our message here is effective screening depends on the discipline as much as software. A strong protocol, reviewer, maintain blindness, consistent labels, and regular backups make the difference between simply using Rayyan and using it well. So after using this practical advantage, we should also evaluate Rayyan honestly. Like every research tool, it has important strengths and limitations. So regarding the strengths, it's free to start. Rayyan's free starting options reduces the financial barrier for trainee-led and unfunded reviews. This is especially valuable for international teams and early career researchers. And also, the interface is relatively easy to learn. So new reviewers can understand the include, maybe, and exclude workflow with limited training. So this reduces the time required to orient a large team. And this is the true blind dual screening. So blind modes support independent reviewer decisions and make conflicts easy to identify. And this strengthens the methodological transparency of the screening process. And then the AI prioritizations. Relevance ratings can help reviewers organize large libraries or studies and focus attention efficiently. So this may reduce the practical burden of screening without removing human control. And peer review validation and produce. Rayyan has been described and evaluated in peer-reviewed literature and is widely recognized in evidence-based practice. So this makes it familiar to many researchers, supervisors, and journal reviewers. And regarding the limitation, screening stage, in the screening stage, Rayyan is strongest in deduplication and screening. It does not complete platform for detailed data extractions, as I mentioned, risk of bias assessment, statistical analysis, meta-analysis, all of that needed, you can say, paid subscription or even so AI or institutional access. So additional tools are usually required for this stage. And advanced AI features may require payment. So the free tier may be sufficient for a standard review, but some newer AI features may not only be available through the paid plans. So teams should check which functions are included before designing the workflow around them. And cloud-based access. Rayyan is primarily cloud-based. So internet connectivity may therefore affect access. So although mobile offline features can help in some situations, so teams should also follow their institutional requirements for data management and security. And duplications need human confirmation. Rayyan identifies probable duplicates, but similar records are not always true duplicates. Protocols, conference abstracts, secondary analysis, and later full publications may be connected without being identical. So human review remains essential. And AI does not replace two reviewers. AI rating may support prioritization, but they do not automatically provide the same methodological role as independent human reviewers. So using AI as a form of replacement would require a clearly justified protocol and transparent reporting. And in routine practice, the safest principle we can use is AI supports the reviewer, but it does not replace our responsibility as reviewer. And Rayyan is a highly valuable when used for the task. It performs best structures collaborative study screening. It becomes even more effective when it's combined with a strong protocol, trained independent reviewers, a separate extraction system, appropriate risk of bias tools, suitable statistical software. So understanding both its strengths and limitations allows teams to use platform realistically and responsibly. So Rayyan turns the lowest phase of a systematic review into a structured, auditable, and team-friendly workflow for free. So instead of managing thousands of records through separate spreadsheets and email chains, the team can work in one organized environment. So every decision can be attributed, filtered, and exported, creating a clear evidence trail. So the second take-home message is blind dual screening and logged exclusion season provide prism-grade rigor by default. So Rayyan supports independent decisions, automatically identifies conflicts, and helps document why studies were excluded. So these functions improve transparency and make final reporting easier. And the message 3 is AI prioritization saves real time, but our decisions as human reviewers retain the final decision, and the AI must be reported transparently. AI can help sort records and bring likely illegal suitable forward. So methodological responsibility remains with us as research team. So every inclusion and exclusion decisions must still be defensible using the predefined protocol. So anyone who would like to explore the platform can begin by creating a free account at Rayyan AI. So for further reading, the original validation paper by the Ozani and colleagues, published in Systematic Review in 2016, provide a useful background on the development and evaluation of the Rayyan. And many university libraries also provide Rayyan LibGuides with practical instructions and screenshots. So in summary, Rayyan does not conduct systematic review for us. It provides a structure that allows us to conduct the screening stage more efficiently, independently, and transparently. And when it's combined with a strong protocol, trained reviewers, and careful documentation, it can significantly improve the way of research team manage evidence. So thank you so much for your attention. And if anyone wants to add anything before sharing my account, let me just open my account. My screen is clear?
Yes.
Okay, so here, all of you doctors, it's Rayyan, okay? So you will gonna open it. If you write just, you can say in Google, Rayyan AI, it will gonna be open. So I think just my internet is not that much good, I'm sorry. Okay, just Either if you can, here, wait. If you already have an account, just you will gonna sign it. If not, okay, you will gonna enter me. If not, you will gonna create account, okay? And then here, for example, wait. Here, this is, here we can say, wait, let me open, show you. Here is the home, okay? So here in home, you will gonna find all the projects already you are in, okay? Either you are the owner of the project as collaborator, or as you can say reviewer, okay? If this project owned by another one of your colleagues and added you as reviewer, okay? So, for example, here, okay? Here, this is all features I was talked about it, okay? Here, for example, this is the general, you can say, platform of the Rayyan. When you open if you are a reviewer, not owner, okay? I'm talking if you are a reviewer. If you are a reviewer and someone give you an access, okay? So you will gonna open the article, okay? The project, I'm sorry, based on the name of your project. After open, this page will gonna open. The page will gonna open like this, okay? So here we're gonna find the name of the project, okay? And then here we're gonna find the subsections of Rayyan. For example, here overview. Overview, here you will gonna find all the important information about your project. For example, review title, here is your project title, the type of review, and then the review domain, biomedical, for example, description. All that it will gonna be added by the owner, okay? So all this information in the overview will gonna be added by the owner. After the owner or the collaborator or the team leader, I'm talking the owner I mean by is the team leader, added all the files and so on, all the number of articles imported will gonna appear here. For example, here imported references, okay? Here I have 168, for example, articles I added, okay? So after added references, okay, then I will gonna click here, for example, resolve duplicates, okay? Here, this at the beginning, we're gonna be 0, okay? And then here, for example, also we're gonna be 0. Then we're gonna be select, for example, resolve duplicates. When clicking resolve duplicates, all Rayyan we're gonna check all references I added. So we're gonna select the duplicates based on similarity percentage. For example, if found, for example, there is 2 articles similarity between them, 80% will gonna be appear. Similarity of them 95% will gonna be appear for me, and give me the final decisions to select which one it will gonna be continued to be added to be continued as with us in reviewing, okay? And then after that, I will gonna select, for example, which is will gonna be deleted. And based on that, Rayyan will gonna give me the final decisions. As the total number of duplicates here, for example, how much of articles had been resolved, for example, how much of articles has been deleted, if there is still articles duplicated, okay? It will gonna be even so mentioned, okay? And then when there is articles, all of articles resolved, so the unresolved articles will gonna be 0, okay? And here we're gonna be find all the team, okay? This is even so added by owner. For example, if selected invite members here, we're gonna add, okay? For example, so not remind it at all. Suddenly, wait guys, I'm sorry. I'm sorry, guys. So here, for example, if I added Dr. Nader, for example,
in the chat.
and then I will gonna select reviewer here. So here regarding using role, guys, user's role, collaborator need even so an access, okay? Collaborator is need for you subscription, okay, paid subscription. So they give you an option even so if you want to make subscription for you and your team. For example, one or two of team, you can pay it for that and give them an access to be as collaborator. So collaborator means they are an owner. They can open and close the blind mode. They can invite even so members, and they can manage all the Rayyan account is you. Okay. So for example, here reviewers. Okay. So then, for example, I can write even some message for us. For example, مثلا reviewers for screening. Okay. Then I will gonna send invite. So invite, this will gonna appear, for example, in Dr. Nader, okay, in his email, and it will get, you will gonna be giving you notifications that it has been successfully. And then when we move to the review data, here we're gonna find all references, okay? Here we're gonna find all references, and then here is screening, okay? If there is any, this screening is for title and abstract screening, okay? So here undecided, that means you have 0. This filter is very important, okay? All articles or articles here, when you will gonna start articles, screening, you should go to, I'm talking about title and abstract screening. You should go to this section, screening, and then you should select the filter of all articles, okay? When you select filters of all articles, then all articles will gonna be appear, okay? And then paste on the team division. So if, for example, you should review the from first and fourth article and so on. This is based on, maybe the team leader ask you, for example, to sort based on, okay, before starting, based on title, based on rating, based on whatever. Maybe no, the team leader told you no, do not sort by anything. It's make it as the Rayyan default, arrange, and then start screening, okay? And then based on team division and so on, you will gonna do your decisions, either included, excluded, and most important point, this will gonna be dependent on the PICO, okay? Okay, this will gonna be dependent on your inclusion and exclusion criteria. So you can just read the title and abstract. No need even so to click the DOI and go for the full text, read it all. No, here we are talking just about title and abstract screening. Based on that, make your inclusion. If there is exclusions, select the reason why you exclude this article, okay? Then after that, if there is any inclusion or exclusions, all articles had been done, okay? So undecided will gonna be 0. But the most important point, if you are owner, you have to go here to the filter, which is about the mini number. So here, at most 0. At most 0 means what? At most 0 means that you will gonna ensure all articles reviewed by reviewed by 2 reviewers at least, okay? So at most 0, that means there is no articles reviewed by only 1 reviewer, okay? So make sure that all articles, okay, at most 1 is 0, okay? If there is article reviewed by only 1, when you select at most 1, so all the articles reviewed by only 1 will gonna appear, okay? Because even if there is article reviewed by only 1 reviewer, will not gonna be appearing undecided, okay? Also undecided may be 0. And then based on that, you will gonna be review the articles by another reviewer, okay? And also then exclusion and here's the excluded and here's the excluded filter. Here's the inclusion here's the inclusion filter, and here's the conflicts. This conflicts which is resolved, and this is we have to make sure that conflict is zero before moving to the full text screening. Okay, and also here is maybe also it should be zero before moving to the full text screening. Okay. And then here it's our full text screening. Okay, so our full text screening here, for example, here we have all articles. Okay, either you have to add the PDF, okay, or for example here attach PDF. If you couldn't attach PDF, you can open here the DOI, so you can make sure that all reviewers using the same DOI, not using, you can say, article from the another journals or avoiding any similarity. Okay, and you are gonna ensure all reviewers use the same article. Okay, it's the same. All articles, undecided, excluded, maybe, inclusion, exclusion. But the most important point, I want you to pay attention for it. After starting screening, sometimes when you are working, maybe you lost the sessions. For example, you know that internet connection, whatever, the session was taking a long time. AI automatically will, Rayyan AI will gonna automatically refresh the page. So while working on that, make sure you are not going to the undecided, because automatically you will gonna back to the undecided page. Make sure you are back to the all articles, okay, and start from the number you want to stop on. Okay. If you want to create, sorry, I want to turn it for you, but wait. Okay, here we're gonna click create review. I don't know if you can see my screen well. We're gonna click create review. Here we're gonna add your title, okay, and then you will gonna add your review type. Either select it a systematic review, literature review, umbrella, whatever. Okay, meta-analysis. Meta-analysis needed in access, institutional access, and for example, select, and then you will gonna select your review domain. Is it biomedical? Is this something chemical? Whatever your search domain, and then you will gonna add descriptions for review. Okay, here it's depending on your protocol. Wait, let me just write, for example, diabetes. And AI, systematic review, for example, biomedical description, for example, to um, to um, to find can AI uh, oh, can AI, I'm sorry guys. support the diabetic treatment app. This is just an example, guys, from my brain. Okay, and then here, for example, diabetes and AI, for example, systematic review, for example, biomedical, and then create new review. Just because I want to move to the here, it's about uploading articles. So this uploading article, it will get it be from either EndNote export, the main CSF, PubMed, whatsoever. So I have actually ready search strategy. Wait, let me add it. So for example, here is a search strategy. Okay, here is PubMed. Okay, here is a search strategy. Okay, I already just like copy paste my search strategy here. Okay, then I will gonna click search. Okay, for example, search strategy, you will gonna generate it based on your protocol, right? Inclusion exclusion criteria, and then for example, I'm gonna select save. Okay, I'm gonna select from here all articles or results. I'm sorry, and then here, for example, here you have CSV. Okay, and then you will gonna create file. Okay. Rayyan or can treat it or review, you can say, or scan the CSF and also can scan the PubMed, both of them. Okay, and then I will gonna pack here, for example, and then I will gonna select. Sorry. Okay, CSF is not available, so I'm gonna select file. Where is it? It's here. Okay, and then I will gonna select, and then I will then click open. Okay, so from the beginning, you will gonna select the different, just here as example, okay, guys? Either from the EndNote, either from IE Explore, I mean, and all of them. And then I will gonna select continue, okay? And then we're gonna be uploaded, okay? Then we're gonna invite members, okay? Write their email. Then I select role as reviewer, and then write the message for him. Okay. Here, now you are generated your own review, okay, as collaborator. Then immediately Rayyan will give you alert, for example, what you did and what is still remaining for you, which is you should resolve duplicates, okay? Then you can click detect duplicates, okay, and you can click proceed, okay, then it will gonna be in progress. Okay, here. So duplicates is 2, right? And then unresolved is 2. So I'm gonna start resolving. So look here, we're gonna appear for you post. So the final decision regards the resolving complex or resolving duplicates, it's mainly depending on us as reviewer. Okay. So here we will gonna read both. Okay. and then you will gonna decide it based on your protocol which one it will gonna be keep. Okay. For example, here okay, just either select it, for example, based on your protocol, because here I didn't add the protocol. Actually, I'm sorry, I have an internet. Okay, just one had been resolved and one had been deleted. Okay, my internet connection is not much strong, you can say. And then after that, I already, for example, invited Dr. Nadir, so needs at least another reviewer. The page is not uploaded well, guys. I'm sorry. If anyone has internet good, we can open. Yeah, here guys, the most important point is we will gonna know how your work is going. So it's your workflow. Okay. For example, the each reviewer, how much of, you can say, articles reviewed by him. Okay. Even so, you will gonna evaluate your reviewing, how much of articles you reviewed. Okay. So how much of articles included or excluded. So all of a workflow you will gonna appear here. Okay. And then you will gonna start your screening. Yeah, wait. You should add your inclusion and exclusion criteria here. Okay. Here is the screening criteria. Okay. So in screening criteria here, you will gonna write your inclusion criteria, and then you will gonna add, and then here you will gonna write your exclusion criteria, and then we're gonna be add. Okay. And then you will gonna, if you want to invite members, you will gonna click here. If you want to edit any information regarding description and so on, we're gonna make it here. Here is the Prisma flow. Okay. If you want later on, after finishing your full text screening and so on, it will gonna be appear all of that. This is the Prisma. Okay. Here, which is that why we're removing duplicates, why we should know how much of included study, how much of inclusions, because to fill this form at the end. Okay, or this flow, we can say. And also yeah, here in screening there is some I think it's you can add labels, or you can for example divided your team. This is a blind mode. Okay, guys, so you can divided your team based on samples, but this is need subscription. Okay, for example, we're gonna select مثلا or reference. Okay, 46 وفلتر 46. For example, press sample name, for example, per one, and then percentage, for example, determined for him 25%. 25. That means all those who is in per one, we're gonna review 12 studies. Okay, and then you can add another sample, and then you can create. Okay, so automatically the Rayyan AI will gonna categorize this. We're gonna categorize the samples. Wait, let me find it here in the filter. Here, for example, just when the reviewer click the sample's name, for example, per one, so we're gonna appear only 12 articles. if created, for example, pair 1, pair 2, it will gonna be divided 3, 4, and so on. So each, for example, 2 reviewers or 2 members from the team, we're gonna just select the pair, and then we're gonna review just the articles included inside. Okay, this will gonna help to manage your team tasks if you have subscription. And also here in full text screening, here in screening, you will gonna start screening. Okay, here is undecided for us is 46, right? So if me and Dr. Nadia want to start screening, we should click here, all articles, and then we should go based on title and abstract, make our decisions, okay? If there is any internet disconnection happen and so on, we will back again and click all articles. For example, if it's include, sorry, it will gonna be, for example, appear as include, okay? Then I will know where I stopped, okay? Because if it's closed, automatically I will gonna let you back to the undecided, to the number of undecided articles, okay? And immediately Rayyan will gonna starting to account how much of included studies, how much of excluded studies, and so on, okay? And then after that, we will gonna either, for example, resolve the maybe or resolve the conflicts. Conflicts will gonna appear after, you can say, finishing all articles and closing the blind mode, okay? And then we will move to the full text. Full text based on, we're gonna add articles, okay? And then we're gonna start, and when we click here, add articles to the full text, we should ensure that here you have 0 undecided, you have 0 maybe, and you have 0 conflicts. Then when you click full text screening here as add articles, just you will gonna add included articles, okay? No any other articles will gonna be added, okay? And then again you will gonna start either to add PDF, which is better, or if it's too much articles, you can add the UI here just so Teams can open and then screen. And then you will gonna include the studies, and based on that you will gonna export just so data risk of bias. Okay, let me show you actually in another here. Just I want to show you how can use full text screening after included. You can here data extraction can be used here. I added some data extraction, but I don't know where is it exactly. Wait. Yeah, here, for example. Here in data extractions, you need, for example, to all PDF to be attached. If you have subscriptions and so on, the same way, you will gonna open the data extraction, and automatically you will gonna select same when you edit full text screening, just included studies to be go for the data extraction. And then based on that, for example, here all PDF, collaborator can add or PDF, and then you can click. And then we will gonna start. I think just my internet is not good. Here you can add the questions of your protocol, okay, of your studies. Okay. Here, I'm sorry. And then risk of bias. Risk of bias also can be, you can add articles, for example, here, because I think depends on, like, risk of bias will gonna be measured depends on if you used it in data extraction, then you will gonna include all articles in risk of bias. There is another study already I read it that I don't know which one, but risk of bias also, Rayyan here, we're not gonna assess automatically. No, it's based on the risk of bias tool. You select it, and then you will gonna answer all questions of risk of bias. I think that's all. Thank you so much. If anyone want to add any thing, share his screen. Feel free. Thank you so much, all.
Thank you so much, Dr. Malaz, for this extensive, very useful, I think, explanation and demonstration of how to use Rayyan. It's a very useful tool. So hopefully all of you will know how to use it, and hopefully it will help you. Thank you so much again.
Thank you so much, all of you.
If no more questions, we can move on to congratulate Dr. Asma. And Dr. Asma presented 2 posters at the Alzheimer Association Annual Association in London, UK. Dr. Asma, if you are still here, please share your experience, your reflection, and how did that go? Congratulations.
Hello, Dr. Nadir.
Hello.
Thank you for you, Dr. Nadir, and for the team for providing me this opportunity to present our projects at the AAIC, which is an important event and attending by people from different backgrounds, including physicians, scientists, radiologists, and even social workers, and also family members. And it is a great opportunity for me, and it is for and also improve my presentation skills and increase my confidence. And also, I want to speak about our posters presentations. So many of attendees were interested and stopped by our posters. And regarding the AI, simplified dementia care resources, I think many of reflections that we received, it is about how it is simplified this dementia care information. Some of those who asked about our project showed their interest because this make easy for them to communicate with patients and to explain the information about the dementia and Alzheimer disease, especially they facing this problem regarding counseling. So they showed their interest because the AI tools make this information easier to understand. And also, some of them asked about why did we choose as this GPT and Gemini. And I think we received positive feedback, and I think we should move forward to either to implement our results or to publish our work. And also regarding the care response, the mobile app, many attendees also showed their interest, especially those with who has family members with dementia or Alzheimer disease. They showed their interest because they facing difficulties with managing psychological and behavioral symptoms of dementia, and also because this app will provide them medications free steps to manage these symptoms. So some of them mentioned this point of they giving medications to calm the patients, and so they interested because this app provides medications free guidelines. And also, I think implementing our work or published it, I think will help us, and also will help caregivers to get benefits of this project. And also, for who will going to present posters, I think the big advice that you give, that you, Dr. Nader gave to me, is that and there's, this project is yours, and who you know much about it. So the presentation will be natural, and the confidence will come from here, from that this project is yours. Overall, this experience was amazing for me because especially this is first time to attend AIC, and also for attending conference. I think it will be good to plan your day before you went there, because I for the first day I didn't do this, because between the time that you attend by your poster, there is a time that you will be free to attend other sessions about developing topics, or to move between posters to explore more. And that is it. And thank you again. Thank you for the team for this great work, and for you, Dr. Nader. Thank you so much.
Thank you so much. Really, we appreciate your help and your great work presenting this, and it's very nice to see how this impacted the audience when they visited the posters. So thank you so much.
Thank you.
How was the conference itself for you?
So the conference is very interesting, especially because it is giving you idea about what is going on, what is new topics and area of interest. I think I attended many sessions about developing topics. One from them about new amyloid. I think it is amyloid anti-amyloid targeting therapies and their side effects, and also about so one of the side effects that it is people interested about it is ARIA, which it is about amyloid imaging. I'm not sure about the full title, but the idea it is about the imaging changes that associated with amyloid targeting therapies. So it is associated with imaging changes, and sometimes associated with symptomatic or symptomatic side effects. And also regarding people interested about tau, I think 217 as diagnostic tools for Alzheimer's disease, early diagnostic tools before imaging, because it is rapid, and it is decreased time for diagnosis before. I mean, it is decreased time to confirm the diagnosis. So it is will give opportunity to intervene early. And also, for one of the topic, one of the areas that new amyloid therapies, like donanemab, I think, and it is role, and also about time of intervention of this drug, or the best time for giving these drugs, these medications, I think. Also, there's also epidemiological areas, like there's futures area for research for social determinants of dementia and their health and their social determinants of health and the risk of dementia. So they encouraging to do more researches about this topic. And also there's many other sessions that I couldn't attend all of them, but I have opportunity to attend them now on demand virtually. So I will explore more. And if anyone has any interest in any area, so I can explore more from these topics.
Sounds good. Thank you so much for sharing. I'm very glad that you attended and you are able to present.
Thank you,
Thanks for
Dr.
sharing. You're welcome.
You are very welcome.
Any other updates for you guys, those who are here?
Hi, Dr. Nadir. Actually, I'm
Hello.
Dr. Rania Babikir. I'm originally from Sudan. I'm a Canadian citizen. And I just joined today for the lecture. And I don't know, is it every Saturday? And what about the schedule regarding the presentation and all of this? Because this is the first time to attend. If you give me a brief idea about the course, I will be appreciated. Thank you so much.
You're welcome. Shine, thank you and welcome to the program. So yeah, we meet every Saturday at 2. Usually we spend 2 hours or some time, but sometimes we go over. The teams, we have teams by color. So you will be, I believe, in red color, number 4. And your team leader will discuss with you what topics and so on. So they will be in touch with you. As far as Saturday Zoom meetings, it depends on your availability. Each team will be assigned, let's say, a week. Next week will be the yellow team, for example. So the members of the yellow team will see who will be available during that day and will divide the topics between them. Sometimes a topic might be presented by one person or more than one person. Sometimes they may need some help, so maybe they are not available for one reason or another. So in the big WhatsApp group, Dr. Marwa will ask for volunteers. Let's say next week you are available. So you will look at the agenda and see what topic interests you, and you can either present the whole topic or part of the topic. Let's say you and Dr. Fatma will be available and you are interested in the same topic. Maybe you can reach out and say, I will present this, and Dr. Fatma also interested, so you can divide that topic between both of you, if that makes sense.
And yeah, it makes sense. And how can I join the WhatsApp group?
So I sent you a welcome email. In that email, you will have the instructions, but one of you, Dr. Malaz, maybe you can share or you can add her to the big WhatsApp group. So we have 2 groups most of the time. We will have the big group that has whole fellowship members, and then we have a team-based group where you have your red one group, only the members in that team and the leader. So you will have 2 groups basically. If that makes sense.
How can I join my group, red group you told me? Is it the same group that for today?
So let me just add Dr. Yusra will be Abdelhadi will be the leader for the red team number 4. So she will approach you. I sent her the list of all the new fellows, so she will be the leader for that. I can send you here the email or her contact email is on the chat now.
Yeah, okay, that's amazing. Thank you so much.
You're welcome. But you're welcome and welcome to the program.
Yeah, thank you so much. It's really amazing program.
Oh, thank you. Thanks.
Dr. Nadir, also
Yes.
Dr. Al asked me about publication, and she said that she spoke with you about it. So, what is the next step, or
So she you can both work on this, so she can create a team. And basically the idea is to convert this from a poster to a paper, and so you start writing a manuscript, and so basically you will collect more evidence, like supporting references for the background, and if there is anything in the literature, and then go over the method, what we did, and the result, what we have, and then the discussion. After you're done with this, you see which journal you want to publish in. Most likely Alzheimer's Association, they have their own journal, or any neurology journal, or dementia journal, or technology. So there are different options for you to publish. If you have fellows from Sudan or from somewhere that's affected by the war, let's say, when you submit to this journal, some of them may have discount or free for authors from these war zones. Otherwise, some of them might be expensive to submit to get published.
Okay, I understand. Yeah. Okay. So I will speak to her and to start this process.
And you can do two out of these 2 posters. You can write 2 papers if you want to do that. If you have some team.
Yeah. Okay. Yeah. It's some of the team asked about this, about publication. So yeah, we will speak with them, and I think many of them interested with this.
Sure.
Yeah.
Sounds good. Sounds good.
Okay. Thank you, Dr. Nadia.
You're welcome. Thank you. Any other questions? Any other comments? Any other ideas? Updates? All right. If not, I'd like to thank you all for your attendance and patience. Thank you so much for presentation, for all those who attended today's meeting and presented. Thank you for those who will watch the recording in the future. Thank you in advance, and we'll see you next week. And if you have any questions, please reach out to me. Thank you. Have a great day or night. You're welcome. Thank you. Thank you all. Thank you.
Thank you so much. Have a great one. Bye-bye.
You too. Thank you, Dr. Rania.